we don't do this anymore to put babies on cardiopulmonary bypass. We have surface cooling that's a little nicer. It's uncommon that we do very large incisions in tetralogy of Fallot because of the late observations of ventricular arrhythmias, poor RV function, and obviously pulmonary valve replacement has become part of this operation. But that took 20 years to know. We didn't really start routinely putting in pulmonary valves. The families all know it now, but we didn't put it in until probably the early 90s routinely, and now we do it in the cath lab. One of the original modifications of the Fontan has been now avoided because of the arrhythmogenicity and thrombogenicity of that huge right atrium. And we're going to be talking about why we stopped doing these two operations, the mustard on your left and the Senning on your right. And it took about 20 years from these operations for people to recognize that arrhythmias, particularly sick sinus syndrome and ventricular dysfunction in many, systemic RV dysfunction, led to the notion, probably in the late 70s, early 80s, that an anatomical repair of transposition might be better. When I was just completing my training, this is a little baby that I took care of after an arterial switch operation. They look much different than now, and I'm going to come back to this. But it was a leap of faith to do an operation in a newborn with, at that time, a 20% mortality risk for the potential long-term benefits compared to a mustard or a Senning. And I was fortunate to be in Boston Children's at that time and had the opportunity to, this was the first paper that I had the opportunity to write, and it was about the first 50 arterial switches. And we said in that paragraph of discussion, we'll continue to closely follow these patients and report on the status of the supravalvular and coronary anastomoses, the neo-aortic valve, long-term ventricular function. And this was written 32 years ago. And here we are today. There's a neonatal baby just about to have a switch on your left and looking at all of these complex reconnections that take place in the arterial switch operation. You could see the pulmonary arteries are anterior, the so-called Lecompte maneuver. I am now beginning to call it the Nutcracker maneuver, where these pulmonary arteries basically embrace the neo-aorta like a nutcracker. So just to close, here's my patient. His name's David, and he's happy for me to show you this. He then turned into a high school senior and went to prom. He then got married, had his own baby, and I find it particularly interesting that he's holding his own baby. This is the same patient right here, in exactly the same position I photographed him 32 years ago. And I told him we were having this meeting. He sent me a new picture of his little girl. And he's very happy to show her off. So we're going to talk about what's been learned about the growth and the long-term outcome of that complex neonatal operation into young adulthood. And with that, I'm going to turn the presentation over to three amazing cardiologists and specialists in imaging. Dr. Laura Oliveri, who's my colleague here at Children's National, who specializes in very complex multimodal imaging. She's the director of the 3D Cardiac Visualization Laboratory here. And her main interests are the optimization of cardiac MR for small children and babies, and also being a mom to her two little girls. Dr. Meryl Cohen, who I've known a very long time and is a dear friend, and I'm glad she's muted because I had no idea what she just said. And Meryl has many titles, and she's a professor of pediatrics at the University of Pennsylvania Perelman School of Medicine. She runs the registry as well as the fellowship director in the past, and I'm really happy to have her discussing this. And finally, Dr. Isra Valverde, who is the head of the Department of Pediatric Cardiology in Seville, Spain, and also a locum consultant at the Evelina Hospital in London. And his clinical expertise, as you will see, is in advanced 3D imaging, echo, MRI, and CT. And the group, they met together before we had this meeting. So instead of having talks that may have been redundant, they're going to do almost a tag team presentation on imaging the child and young adult with the arterial switch. So thank you, all three of you, and I look forward to these presentations. Who's going first?
I think that's me. Good morning, good afternoon, good evening, everyone. I'm Laura Oliveri. Thank you to the organizers for inviting me to present, and thank you for the kind introduction. I'm going to talk about multimodality imaging, focusing on the pulmonary arteries and aorta. I have no disclosures other than the fact that I use all three tools, and so I hope all three echo, MR, and CT tools, so I hope to provide a balanced assessment of all three. So first, we'll talk about what are we looking for in this population of patients. We'll then move into describing the modalities and talk about how are we looking, and then go through some case examples to kind of illustrate the strengths and weaknesses of each. So the majority of what I'm going to talk about is actually from Dr. Cohen and team's lovely paper that hopefully was circulated to the group. If you read one paper after this session, please read this one. It's phenomenal. And again, we're mainly focusing on survivors of the arterial switch operation that you can see in the lower left, but we'll also include considerations for the Rastelli operation and Nikaido/Rev operations. So let's start out. What are we looking for? What are these patients specifically at risk of developing? And again, we're going to focus here. So we're thinking about the outflow, right and left ventricular outflow tracts, branch pulmonary arteries, ascending aorta, and then also focused on the valves. All four valves matter, but in particular, the neo-aortic root and neo-aortic valve. And
Laura, I'm sorry to interrupt. Are the slides up for people? They are? Okay, it's my end. Thanks. Sorry, Laura,
okay.
Keep going.
No, that's all right. You just gave me like a panic. Thank you for double checking though. Moving into kind of the tools, how do we look for these things? We have echo, we have MR, and we have CT. There are considerations that are technology specific. So how available, portable, do you need sedation? Is there radiation exposure? And then interestingly, safety with pacers, which I'll touch on further in the talk. And then there's also patient-specific characteristics. What are you looking for? What is your patient potentially at risk for? And so, you know, echo can assess a lot, and it's really the mainstay of how we assess our patients. But again, looking for things like the right ventricular outflow tract, branch pulmonary arteries, these are located right under the sternum, and it's very difficult sometimes to see with echocardiography. And so moving into an advanced imaging modality to assess those things is often a good idea. And I find that people are often surprised by what they find. So let's just briefly touch on how to choose between MR and CT. So certainly MR is accurate. Multiple studies have shown it's superior to echo in assessment of branch pulmonary arteries in the switch patients. CT should be considered in special situations. And again, all these tables are from Dr. Cohen's paper. And so specifically when there's a patient with a legacy device, so a non-MR conditional device, probably, you know, you want to think about CT, although there's phenomenal data out of Hopkins showing really favorable risk-benefit ratios of scanning patients with legacy devices with appropriate informed consent. Certainly, if there is something right, some metal thing right where you need to see, MR may disappoint, and so CT is also should be a choice there. Certainly, if you're looking to assess prosthetic valves, MR is not a great modality, so would opt for CT or potentially other forms of imaging like TEE. And then Dr. Cohen will get into this further, but any assessment of coronaries beyond the origins, really CT is often the better choice. But the main thing is that, you know, different institutions invest differently in these different technologies. So consulting with, knowing what your local, where your local expertise and your local resources have been invested is probably the most important thing. And the version of me that is at all of your hospitals and institutions can, I'm sure, would be happy to help you make the decision about your patient. So I thought we could just quickly get into some cases. So this is actually, this is a case I did last week, a little baby, 18-month-old. We can see here the right and left ventricular outflow tracts from the subcostal view using echocardiography. We can see here there's an intact atrial septum and there's normal biventricular systolic function and size. The sonographer then moves up into the chest on an 18-month-old, and this is the best view we get of the branched pulmonary arteries. Due to concern that the septum potentially looked a little flat in that short axis view, I showed you a cardiac MR was ordered, and the patient was sedated for this. So this is the child's MR. This is a free breathing stack of axial cinae. The blue arrow indicates the right ventricular outflow tract that, again, is right underneath the sternum, exactly underneath the sternum frequently. Coming down through the heart, it's a nice way to kind of globally assess valve function, ventricular function. Here's a right ventricular outflow tract cinae. And then after injection of contrast, an MR angiogram can be performed, which will show the Ct, the Nutcracker, as Gil called it, the anteriorly draping pulmonary arteries. And hopefully you notice there, we'll go back up, but hopefully you notice there that there is a kind of a positive contrast at the proximal origin of the left pulmonary artery, indicating narrowing kind of in that kind of left-right AP view. This patient also has an anomalous left upper pulmonary vein, if anyone's wondering what that extra circle is. This data set can be sliced and diced, and so, you know, on multiplanar reconstruction, you can look at a sagittal and see here's this circle is the distal right pulmonary artery, and as we come back leftward, you see it drape anterior to the aorta. And then you can see that narrowing a bit better in a different view of the left pulmonary artery. So MR, especially contrast enhanced MR, is a beautiful way to see this. This is a volume reconstruction. These are often a little bit over smooth and may give the wrong idea. Here, this looks interrupted. The LPA is not interrupted. It's just narrowed in the AP view. But these are a great way, and Israel will talk more about that, great way to get complex data communicated quickly. We also will do volumetry, measuring end diastolic and systolic volumes of the right and left ventricles, and we'll do flow imaging, phase contrast flow imaging in the branched pulmonary arteries to understand if there's a flow imbalance associated with a stenosis. So I just did that last week, so I believe that child's on for the cath lab later this month. Here's a second case. Again, this is a slightly older patient, 8-year-old, coming in for screening. I think, again, you can see, if you look at the short axis, the septum might look a little flat, but normal biventricular systolic function. Again, a really nice assessment of outflow tracts from the subcostal view, even in this 8-year-old, right and left ventricular outflow tracts. Up in the arch, we have unobstructed arch. And then down on the lower right, we have a left ventricular outflow tract that shows a mildly dilated aortic group and no insufficiency. Here's attempt number 1 at the branched pulmonary arteries. More attempts of, here's the right pulmonary artery here in the middle, so attempt at the left. I don't know why an 8-year-old is crying, but clearly this didn't go well with him. And I think he was sent for, actually, this was done without sedation. This is a free breathing, non-contrast 3D SSFP MR. The blue arrows show the branched pulmonary arteries. And as we come back up, what I want you to look at is the right ventricular outflow tract is actually, in this case, slightly rightward of the sternum, and it actually is causing a little fold there in the right pulmonary artery, the proximal right pulmonary artery, and the angle it's coming in at is kind of unusual. Again, looking at this from the semi-coronal view, you can see there is a real stenosis, there a real bend at the origin of the proximal right pulmonary artery. And here is the same view for the left pulmonary artery, and you can see that's just a straight shot. It's like a highway back into the left pulmonary, the left lung. Cine views show normal, again, normal function, a good-looking right ventricular outflow tract, and a good-looking left ventricular outflow tract with a dilated aortic root. Again, volumetry is obtained, and branched pulmonary artery flow distributions are also obtained, which show about a 50-50 split for this patient. Because of the flattened septum and some mild flow redistribution, this patient went to the cardiac cath lab, had that right pulmonary artery stenosis further assessed and treated in the cath lab successfully. And then the last case, if I have time, I'll zip through real quickly. This is a 3-year-old. Again, short axis and 4-chamber views show normal function, maybe a flattened septum. Outflow tracts, again, are very reliably imaged from subcostal. And in this case, we're Dopplering something very high velocity, unclear what it is, if it's supravalvular or one of the branch PAs. Zipping up to the branch PAs, we have nice imaging, echo imaging actually of the RPA and LPA, but no velocities that are Dopplering like what we saw from subcostal. So again, to further investigate, this patient had a cardiac MR and actually 2 interesting findings. First, there is a left pulmonary artery stenosis. And second, as you look at the outflow tract here, there's a large aneurysm or pseudoaneurysm of the proximal right pulmonary artery associated with some significant supravalvular stenosis. This patient also had this treated in the cardiac cath lab. So those are just some examples to show you what an echo and an MR looks like on the same child and how it really can be hard, I think, to assess that supravalvular region in particular. So in summary, echo can diagnose and manage the vast majority of postoperative situations in transposition of the great artery repairs. However, right ventricular outflow obstruction can be difficult to appreciate by echo, so consider cross-sectional imaging early often, and after they get past a certain phase age, potentially even as surveillance. Neo-aortic root dilation and valve regurgitation are common, and they're commonly mild, frequently, very rarely require reintervention. But if you feel like your patient's getting to that point, again, MR is a great technology. And finally, just to remember to use CT when MR can't get the job done, when you're dealing with someone with a legacy device, someone where you need to understand more about the coronaries or there's a contraindication to MR. And this actually is, or if there is a really nice CT resource and expertise in your region. Thank you so much for your attention.
Fantastic images. Meryl, are you up next or Isra?
I'm next, yeah.
Okay, I'm just going to remind people just a few things. The moderators will be taking questions in the Q&A rather than the chat. And after our talks, we should be able to answer all of those. So if you have questions for the speakers, if you could put them in the Q&A, please. And without further ado, Dr. Meryl Cohen.
Can you see and hear, Gil?
Yeah, they look beautiful. Thanks.
Okay, just want to make sure.
Thanks for checking on me. I appreciate it.
Thanks, Laura, for that excellent presentation. I'm going to focus my attention on the coronary arteries after the arterial switch. You'll also hear about this from Dr. Blum later in the session, the fate of the coronary arteries. And I just want to thank Grace and Sasha and Gil again for inviting me to these outstanding sessions. And I too will start with a case, and this is actually a published case from a number of years ago of a 15-year-old who had usual coronary arteries and had kinking of one of the coronaries at the time of the arterial switch, which was revised. The patient was completely asymptomatic and went for his first visit to the adult transitional clinic, where an ECG and echo are routine and standard ways of doing testing on patients who've had the arterial switch, showed no abnormalities, and was referred for a standard at that institution stress perfusion CMR to assess the myocardium of the heart. And I think, Gil, we can hear your typing, so if you can mute. Stress perfusion was done and showed a severe perfusion abnormality, which may be hard for you to see on the screen, but was in the anterior septal and lateral walls during stress. But what is very easy for you to see is that there was essentially left coronary artery ostial atresia with collaterals that developed from the right coronary artery. And so this was completely silent in this patient and is therefore quite scary. And there have been a number of case reports of patients who have coronary complications late after the arterial switch. And so there are two times of concern about the coronary arteries after this operation. You can have early issues, and it's the most, if you have a problem with the coronary translocation during surgery, it's the most common cause of early mortality. It can lead to regional wall motion abnormalities or worse. And often it's the most common reason why a surgeon cannot separate the patient from cardiopulmonary bypass. In addition, we get concerned about these late issues, like the case I just showed you, where the patient may have ventricular dysfunction and evidence of myocardial ischemia, but they can also have life-threatening arrhythmias and even sudden death. And what's most concerning about these problems is that coronary artery stenosis and atresia is reported in up to 10 or 11% of patients who've had the arterial switch, but many of them are completely asymptomatic. Philippe Bonhoeffer, more than 20 years ago, did a beautiful sort of study just looking at assessing the coronary arteries in a large cohort of arterial switch patients, 165 patients, relatively young. And he did prospective selective coronary angiography and was quite shocked to find that about 18% of them had coronary artery abnormalities, of which 20 were either occlusion or major stenosis. And so these were issues that we didn't even know about. And the group in Paris had, with a very large cohort, almost 1,200 patients, looked at coronary artery events being myocardial infarction, sudden death, and found that there was clearly an early problem. And this lower figure here is just a stretched out version of this one. And this is the first year of life. So it's stretched out for you to see. So this is clearly coronary events that are occurring around the event of the surgery itself. But take note of the fact that there are other events that are occurring later in later childhood and early adolescence, such that freedom from coronary events is about 90% in this cohort up to age 20. And risk factors for this type of problem are coronary artery anatomy, certain types of patterns that occur, major operative events, again, revisions of the coronary artery at the time of surgery. Fortunately, only few required late reoperation. And I draw your attention to this very recent study from my colleague down in Delaware. And this is just a small subset of that cohort. And this is 5 patients in their cohort who had severe obstruction or complete occlusion of a coronary artery. And the reason why I find this study concerning is because of those patients, 3 had a completely normal exercise stress test, and 3 had negative myocardial perfusion imaging. So these are the ways we're looking to see if these patients have coronary artery abnormalities, and a majority who actually have an abnormality or a complete occlusion of the coronary artery had tests that we would have said were normal. I'm not going to spend a lot of time talking to you about the advantages and disadvantages of imaging modalities, but I'll leave the slide and these will be available to you. And you already know what, and Laura has touched upon this. I will just touch upon a few of the imaging modalities with the time I have left. So one of the Toronto group has really spearheaded the notion that in the operating room with transesophageal echo, we have the ability to detect when there is a coronary artery abnormality. Here is a 4-chamber view where you can see that there's regional wall motion abnormality. The lateral wall here is not moving as well as the septum. And what you can see when you're actually imaging the coronary artery with color Doppler is that there is acceleration of flow here, which you can see with the spectral Doppler pattern as well. So this can be detected in the operating room at the time, not just by the regional wall motion abnormality, by actually imaging the coronary arteries and assessing the Doppler flow patterns. MRA is now being used relatively routinely to look at the coronary arteries of patients who have had the arterial switch. And this is a study also from Toronto of a young adult cohort in which the coronary artery osteo were visualized in the majority of patients. There were no inducible perfusion defects, but interestingly, they also did SPECT on these patients, and there was disagreement between the MRA and the SPECT imaging in more than half of them, mostly due to false positive SPECT, and I'll touch upon that a bit later. CMR provides not only imaging of the coronary arteries, but assessment of flow patterns, as well as assessment of myocardial perfusion. And that is really an asset of this imaging modality. You see here the left coronary artery in this patient looks relatively okay, but you can see that the right coronary artery is actually quite tortuous and narrows a bit as it makes its way back. And this is shown in the delayed enhancement in this patient using gadolinium in the posterior inferior region of the left ventricle. CT angiography has exquisite resolution. In this cohort of 130 consecutive children, again young, who underwent CT angio after the arterial switch, the overwhelming majority had evaluable studies, and it accurately detected all 12 patients, again, that 9 to 10% range, with significant coronary artery lesions, and also determined the cause of the narrowing in these patients. And I find these next images of CT quite fascinating because it helps us understand why coronary artery problems possibly are developing in this cohort of patients. So here you see a patient who has the circumflex from the right, the most common anomaly of coronary arteries in transposition. So here's the circumflex with the retroaortic course. And you can see that there is narrowing here and stretching, which you see in the angiography as well. But note that maybe this is because the neo-aortic root has dilated over time and distorted the coronary artery between the pulmonary artery and the aorta. This is shown in these other two examples from this paper as well, from the same group. And again, you can see a high takeoff of the right coronary artery here, and it is compressed between the pulmonary artery and the aorta. And here, more profound narrowing of the left anterior descending coronary artery, which has a high takeoff near the pulmonary artery bifurcation. Again, the aortic root is quite dilated, and that may be the cause of the compression. And CT angiography can give us some really exquisite views of the coronary arteries. Here is a beautiful demonstration of a single right coronary artery. So here's the aorta. Here you see the right coronary artery and the left anterior descending making its way over, and you can see how it's compressed between the aorta and the Lecompte and the PA in the front here. You'll see the narrowing as it makes its way back. It's like a vice. And then here you see a patient who has usual coronary artery. So they are not immune to this problem. Here's a beautiful right coronary artery, which looks widely patent. And you have trouble seeing the left because it is very, very tiny. And in fact, there is atresia. There's no connection between the aorta here and the left coronary artery. So this is left coronary artery atresia. I'm not going to spend a lot of time on SPECT imaging. This is probably one of the largest cohorts where it was applied. They found 8 defects, 2 fixed and 6 reversible. All of the patients who had perfusion defects had perioperative coronary artery complications. At the time of the arterial switch, it was not associated with coronary anatomy. And they concluded that this type of imaging is likely should be reserved for patients with high suspicion. In addition to our concern about the anatomy and the narrowing of the coronary arteries, there's also concern that coronary artery translocation may result in problems in the functional aspect of the coronary arteries. And this beautiful study from now almost 2 decades ago, which gave nitroglycerin to patients who had the arterial switch and to a control group, found that only the control group had appropriate dilation of their coronary artery in response to nitroglycerin, suggesting that there is likely endothelial dysfunction in the coronary arteries of patients who've had the arterial switch. And finally, intravascular ultrasound has also showed us something of concern, which is that the coronary arteries of patients who've had the arterial switch can have intimal proliferation. It occurred in almost 90% of the coronaries that they entered in patients who had the arterial switch and in none of the normal patients. And the intimal proliferation is a precursor to atherosclerosis. There were no associated risk factors in this study. And in addition to our transposition multimodality guideline, we have recently published a multimodality guideline on congenital coronary artery anomalies. And so there's more information there. And here is the comparison of the various techniques for imaging the coronary arteries in congenital heart disease coming from that paper. So in conclusion, coronary artery issues can occur early and late. Some of these issues are in patients who are completely asymptomatic. Thus, screening for these problems in adolescence and adulthood is warranted. It's clearly higher risk in a certain cohort of patients, including those who had coronary artery revision at the time of their arterial switch. If they have an anterior location of their coronary artery, so it can be compressed between the aorta and the PA, or intramural coronaries. And this justifies the notion that CT or CMR should be done periodically in the adolescent and adult population. Coronary artery translocation may predispose to early atherosclerotic disease. Thus far, the majority of patients who've had the arterial switch have no coronary artery issues, but these patients are relatively young and only in their 4th decade of life. So I think there's still time to tell where this is going. Thank you for your time.
Thanks so much, Meryl. Really fantastic photos and a great overview. And I think following now is, I don't see him on the screen.
There you go.
Oh, there you go. Hi, Ezra. Are you in Seville or London, or where are you?
Seville right now.
Seville, okay. Dr. Valverde, I'd love to share your screen. It's up there and working. Looking forward to hearing your talk.
Okay, thank you very much. And thank you, the organization, for the invitation and also the opportunity of sharing the talk with Laura and Meryl. So I have no conflicts of interest. Let's see, yeah. No way. So as you know, before the arterial switch operation, the aorta is placed anterior to the pulmonary artery, and the aortic arch curvature is quite wide and resembles the Romanesque aortic arch. So it's after the arterial switch operation and the Lecompte maneuver when the aorta is displaced posteriorly, and this has a severe impact on aortic arch morphology with a severe increase in aortic arch curvature. And previous studies have suggested that aortic arch curvature may be an independent factor for aortic root dilatation, which later leads to aortic regurgitation. Why is it so slow?
Grace, if we take control remotely, will that help advance the slides, do you think?
Maybe.
Yeah, maybe. I'm not a co-host, so I can't do this.
Sasha is, right?
Yeah.
Yes, I can.
Isra, try again and try to advance on the arrows. Sometimes it helps.
Okay.
In the bottom left, yeah.
Yes, it's better that you go directly on the arrow, not in another place.
Do you want to?
Share
You
again.
have to share your screen again, please.
Okay. Give me a second.
Yes.
Yeah.
Don't worry, don't worry. Share again your presentation.
Okay, so if I try now and I share a screen and I share
Okay.
now, if I go here where I left,
Yes.
it should be working now.
Yes.
Okay, so let's see now.
Only with the arrow. Only with the arrow.
Okay, looks better now. So as I said, that previous studies suggested that maybe aortic curvature could be an independent factor for aortic root dilatation. And maybe we have failed to predict outcomes for the past 30 years because our approximation to flow mechanics has been limited to evaluating diameters, peak velocity, and invasive pressure measurements. Our hypothesis is that maybe the information required to predict aortic root dilatation should be within the flow. So flow hemodynamics may be the key to predict what will happen into the future. For this, we performed a study including 15 patients with transposition of the arteries and compared it to control. So based on 4D flow MRI, we generate a finite element mesh to define aortic geometry, and we use an interpolation based on 4D flow MRI to compute all these 16 hemodynamic parameters that you see here, which include velocity, wall shear stress, vorticity, and helicity. And from all the parameters that we evaluated, wall shear stress, oscillatory shear index, vorticity, viscous dissipation, energy loss, and eccentricity were significantly different in patients compared to controls. All these parameters that are shown here are significantly correlated with the increased aortic arch curvature and increased aortic root dilatation in patients after the arterial switch operation. So in this study, what we demonstrated is that in patients with TGA after arterial switch operation, the acute aortic arch curvature is correlated with altered flow dynamics. And second, that the skewness flow distribution of these hemodynamic forces is lastly related to aortic root dilatation. And we know it's a long shot hypothesis, but based on our results, we think that it's the curvature, the leading factor, which truly alters the flow, which in turn is responsible for aortic root and ascending aorta dilatation. So it's not just an intrinsic property of the wall of the aorta or the neo-aorta, it's all about the geometry. And what about the right heart? So in this study, Laura Olivieri and colleagues combine MRI and computational fluid dynamics to investigate the impact of the postoperative layout on the pulmonary blood flow patterns. And they found that the decreased radius of curvature between the PA and the branches is associated with complex flow dynamics and transition to turbulent flow. And as you can see here in the image, because of these geometrical changes, recirculation areas appear, there is a transition to flow instability, and there is a creation of chaotic flow. However, not all the centers have the ability to perform CFD. And this is one of the most clever approaches that Laura did, is what about if they can extrapolate geometrical features to predict increased RV afterload after arterial switch operation? So in other words, can a simple parameter help to predict outcome without the need of complex computational fluid dynamics? And for this, they evaluated two simple parameters that any center can measure. So one is the bending angle, as you see here, which is the angle between the long axis of the RPA or the LPA and the MPA. And the second is the radius of curvature, which is a measurement of how small the bend is across the proximal portion of the pulmonary artery. And in conclusion, what they found is that the radius of curvature is correlated with the RV afterload. So the smaller the radius of curvature, the higher the RV systolic pressure. And interestingly, PA diameters, they do not correlate with the RV afterload. And what are the clinical implications that they suggest? That while discrete linear PA stenosis can be readdressed with surgery or catheterization in order to improve pulmonary blood flow distribution, the remaining substrate of abnormal curvature and imposed RV afterload will still lead to increased RV afterload. And finally, finishing with all the novelty of 4D flow and computational fluid dynamics, which are really helpful to predict the future, we can use advanced imaging to work on the current limitation that we have right now, which is extracting all the potential of 3D imaging using 3D printing and also virtual reality. And what do you need to do that? I mean, the process is quite similar between the two modalities. What you need is a 3D image, such as MRI, CT, 3D echo. Then what you do is just you segment the image which means that you select the structure of interest, keeping the myocardium, blood pool, valves, removing the lungs and bones. And then you create a 3D virtual model, which is then processed and ready to send either to the 3D printer or either to the virtual reality software. And what are the potential application of 3D printed model in post-arterial switch operation? We think that there are two main applications, which is the catheter interventional planning and the surgical planning. However, for that, we need to take care of two main requisites, which is, are the 3D printed model replicas accurate? And second is, do they reproduce tissue property for distensibility for catheter intervention and softness for surgical planning? So one of the first concerns about this new technology was the accuracy. Do 3D printed models really represent reality? And what we did is we compared 320 anatomical structures between medical images and the 3D printed model. And what we found is that 3D printed models are really accurate. They have an accuracy below 1 millimeter of bias, which is really good for surgical and also for interventional planning. The second question that we are always asked is about distensibility. I mean, during a balloon angioplasty of pulmonary arteries, we have no clue of the patient PA distensibility. What we know is that a PA can be enlarged up to 3 times the diameter, and for this, we use high pressure balloon. For example, in a PA stenosis that we create here of 4 millimeter diameter, we can enlarge up to 12 millimeter using an Atlas balloon, inflating at a nominal pressure up to 12 atmosphere, and the balloon should not burst. So for that, we reproduce different experiments with different material and wall thicknesses until we found that polyurethane with a vessel wall of 4 millimeter thickness reproduce the same properties of native tissue, and therefore we can use this model to plan intervention. And finally, in the largest multi-center study about the potential use of 3D printed model for surgical planning, we also proved that in this case of a patient with after arterial switch operation with subaortic obstruction, in which the 3D printed model really helped to plan the Cono procedure. And we also play around with different tissue properties and material to find a material which is similar to myocardium, where surgeons can train to cut and suture and place patches, not only for complex intervention, but also for training. And finally, the other option will be like, you may not need to send the virtual reality model, the geometry model to 3D printing. You can send it to the virtual reality. And it offers several things that you cannot do with 3D printed model, which is cheap. Here you see that you can remove the skin, you can remove the gut and see if there is any compression. The cost is really low compared to 3D printing because you can play around in the machine endlessly. You can visualize the model. For example, this is the previous case of a patient after a arterial switch operation. Here you can see represented the myocardium, the blood pool. The surgeon can play around, enter into the heart, having the same view, entering into the aorta, as you see here, like if you were planning the Cono procedure. And it's really, really nice. So in summary, 4D flow and computational fluid mechanics, the outcome prediction requires more than diameters and peak velocity. In the near future, we will incorporate terms such as wall shear stress, energy loss into our routine clinical practice, no doubt. We will be able to predict outcomes with much better accuracy. And for this, we need bioengineers as part of our clinical team in the surgical meetings. And finally, regarding 3D printing and virtual reality, I'm pretty sure that younger surgeons and interventionalists will start demanding these new visualization techniques to plan complex intervention, because segmentation algorithms and faster 3D printers will provide 3D printed models and virtual reality models faster than a radiology report. I'm pretty sure about that. Thank you, everybody, and I will stop sharing now.
Isra and the rest of the team, those were just really wonderful presentations. I'm struck and a little sobering that here we are 3 decades out, and like we talked about at the beginning, sometimes it takes a bit of time to know what the challenges are. But the more I look at that stuff, I think that the pulmonary artery reconstruction in this operation now needs to be rethought. It really looks like the combination of the anterior compression from the Lecompte causes problems to the PAs and the neo-aorta and the root and the coronaries. It took us a while to figure that out, but I think now's the time to move along with that. I'll be interested in the discussion to see what people think. I'm sorry, I'm just going to put this on here. Again, thank you both, and I look forward to the questions. I'm now really proud and happy to introduce Dr. I'm going to butcher this, Henrik, but it's Henrik Grotenhuis from just a great center in Utrecht at the Wilhelmina Children's Hospital. I've had a chance to visit there, and it's such a beautiful city. And this report that I saw really caught my eye on what causes exercise impairment after the arterial switch. And I think you're all going to learn that it's a follow-up of the type of things that we've just been talking about. So without further ado, if you would like to share your video, Henrik, that would be fantastic.
Thank you, Gil, for the very kind introduction. Utrecht is a very nice place indeed, although I'm sitting inside. Can you all hear me? Yes. So for the next 50 minutes, I would like to touch on the exercise capacity of patients with the arterial switch operation, especially in light of the long-term prognosis of these patients. So, from a relevance perspective, why is it relevant to know? Because I think all the previous speakers, they all mentioned that prognosis of this patient group is excellent. They all seem to have a normal life expectancy of what we currently know from the long-term data sets that we have available, and as a result of that, these patients will have an active lifestyle when you encounter them in your clinic, and active sports participation is something which is part of their day-to-day life as well. And for you as a clinician, it's really key to be able to understand, but also to be able to guide them from a day-to-day life perspective. And I think if we look for the main thing is that you should expect normal exercise in these patients, and clearly if it's abnormal, an underlying condition should be excluded. That's the paradigm that should follow for patients with after the arterial switch operation. And I think this is all in contrast with the darker era of the atrial switch as surgical procedure number one for transposition. So for the main of my talk, I would like to focus on exercise capacity, incidence of abnormalities, and magnitude of it, the factors affecting exercise capacity, and shortly touch on guidelines how to follow these. So this is a recent systematic review that we published on left ventricular function and exercise capacity in transposition after the arterial switch, and based on a pooling of 21 studies. Roughly, you can sort of estimate that 1 in every 5 arterial switch operation patients will demonstrate an impaired exercise capacity, either expressed by a reduced peak O2 uptake or a reduced peak workload. And the other striking aspect that's often seen is a mildly reduced gonotropic response in response to exercise. In light of the coronary transfer that is part of the arterial switch, it's also key to know that there's no obvious myocardial ischemia that's routinely seen during exercise testing. And what we found was that a few things: oxygen uptake, as you can appreciate in the lower part, oxygen uptake is consistently lower in patients after the arterial switch operation, with a pooled average peak O2 uptake of about 90%, which is subnormal. It's and always better than other disease entities like tetralogy or single ventricle lesions, but still clearly reduced. And in addition to that, the peak heart rate it's also lower when compared to controls, with the same number of roughly 90% of predicted. And then in 2 studies, peak workload was also significantly reduced. So is this something that we should worry about? Is this something that we as clinicians should be worried about? And what should we think of this? Well, I think it's key if you address this. I think it's key to think of the list of sequelae that is associated with the arterial switch operation, and then my biventricular function, a degree of myocardial fibrosis, any perfusion defects related to the prior coronary transfer, the chronotropic insufficiency that I previously mentioned, degree of aortic insufficiency, which we often see because the aortic roots tend to dilate, and with that you can have a central aortic valve insufficiency as a concomitant lesion. And then finally, the MPA and the PA branch stenosis that were nicely shown by Israel in the previous talk. This is it's a busy slide, but this is a recent paper from the Toronto group that I participated in. It's a multi-center of the multimodality imaging approach using MRI and echo. And what you can appreciate is that LV ejection fraction is entirely normal in this patient group. The dimensions are slightly increased, perhaps the suggestion of some mild remodeling. A strain where both sequential and longitudinal strain were slightly abnormal, but still within a reasonable range. So you can conclude from it that systolic LV function is generally preserved in this patient group, and from that, it's no surprise that none of the studies that have sort of assessed this relationship between LV function and exercise capacity have found a negative relationship between the two. So myocardial performance in itself doesn't seem to play a role in reduced exercise capacity. What about myocardial fibrosis? That can be expected if you have had prior surgery, cardiac surgery, or a period of cyanosis. From the same imaging paper, you can appreciate the T1 values are slightly increased for the LV, although the ECP values were within normal range. So that suggests a mild degree of LV fibrosis. But unfortunately, up to now, there's no studies that have directly assessed relationship between myocardial fibrosis and exercise performance after the arterial switch operation. So that's something that needs to be further studied in the future. What about myocardial perfusion? Well, there's a slightly older paper. I know one of the senior authors is part of this webinar, so I'll put this very in a positive way. It's slightly older. Well, the majority of arterial switch operation, they demonstrated in the study small defects at rest that you can appreciate in the figure on the right. It's mostly the apical lateral free wall of the LV that was affected in this case. There was direct comparison with exercise testing, and of interest was that these defects were either stable or even improved from a perfusion perspective with exercise. So, and this was all in the setting of normal exercise tolerance, no symptoms of these patients, and no ischemic changes on monitoring. So these findings sort of suggest that the myocardial perfusion is at least adequate both at rest and during exercise. And this is in keeping with the same multimodality paper, which with MRI demonstrated no perfusion defects, no delayed enhancement, and normal proximal coronary arteries. So after this transfer of coronary arteries, perfusion defects or coronary physiology seems to be adequate for not only resting conditions. There's a few papers that have demonstrated abnormal coronary flow reserve up to mild degrees, but again, also in those studies, but there was no correlation with this either with ischemia or exercise performance. So from a myocardial perfusion perspective, it doesn't seem to be play a major role from an exercise perspective. So what about chronotropic insufficiency? This can be attributed to sympathetic denervation, similar to transplant patients. And all studies that have been working on this, they also show clinically reduced peak heart rates in a majority of patients. But it's conflicting on how to interpret this and how to what the impact was on exercise capacity. As it's a few studies, Giardini is a great paper to read on this. But same from a study from our institution as well, with similar numbers where true chronotropic incompetence was only present in about to 45% of patients. And what Giardini proposed in his report was that the majority of patients had sort of complete cardiac reinnervation within the first decade after neonatal surgery. So when reduced exercise capacity comes into play, which is usually the second decade of life, that doesn't seem to be a major role for clonotropic incompetence. The only thing that was associated with clonotropic insufficiency was a complex coronary anatomy to start with, probably related to a more extensive surgery and a more complicated mobilization of coronaries. But that was the only association that could be found with clonotropic insufficiency in this patient group. What about aortic insufficiency? I think the numbers are pretty similar for most of the studies that are available. This particular study that we recently published on the echocardiographic and MRI parameters that are associated or predictive of abnormal exercise capacity in switch patients. We found neo-AI in about 14% of patients in a group of 80 to 90 switch patients in total. All of them had mild degrees of neo-AI, and there was no association with exercise capacity. And this is in slight contrast with Dr. Kugler, who had a larger cohort of about 120 patients after the switch. We had a few of 4 or 5 patients with moderate to severe AI, and in those particular patients, it was significantly associated with reduced exercise capacity. So, from this perspective, you can appreciate that significant AI, neo-AI, probably has an impact on exercise capacity in this patient group. And then coming back to the last factor that may have an impact on exercise capacity, and that's the clear the real strongest predictor of exercise capacity that numerous papers have described on after assessment of exercise capacity, and that is stenosis of the main pulmonary artery, either expressed as a smaller cross-sectional area or increased gradients on Doppler imaging. So a smaller or pulmonary true MPA stenosis is associated with reduced exercise capacity. And what you can appreciate from this graph is that in the first below 18 years, it's a pretty flat curve, but then after in the older generation, there is a true significant relationship on multi-regression analysis between smaller cross-sectional area in this particular graph section with reduced exercise capacity. Pulmonary branch, and this is from a background perspective. Again, MPA stenosis can be expected after the Lecompte maneuver with stretching of the PAs and the anterior positioning of the pulmonary artery towards the aorta. In normals, RV stroke volume can be increased with exercise with minimal elevation of right-sided pressures, and that is related to the very low pulmonary vascular resistance that is typically very accommodating for increased volumes of blood with increased cardiac output during exercise. But if you have this pulmonary stenosis, this MPA, which is smaller than it should be, your RVSP will disproportionately increase during exercise, which will limit the increase in RV stroke volume, hence will reduce the exercise performance of that particular patient. And the graph on the right will demonstrate sort of the increased right-sided pressures with flattening of the interventricular septum and increased TR gradient, as you can appreciate on the left figure. What about pulmonary branch stenosis? Because that's something which is often seen as well. This is a rather old MRI figure, but I'm always struck when I see it. When you start with the right-sided image during diastole, you sort of appreciate from a glance that both branch PAs appear to have the same size, almost like symmetric in size. But what happens during systole is there's a huge discrepancy in size, and also in flow between both branch PAs. And what's the reason for this? Well, the reason is that during systolic ejection, the LV ejects all this blood into the aorta, and the aorta sort of swells with it, and with the very adjacent position of, in this particular patient, of the proximal RPA, that RPA is actively compressed by this swelling of the aorta. And with that, it's not only compressed, it's squeezed, and therefore it can't accommodate a lot of blood anymore, and the majority of blood will flow through the LPA. So if you would, in this particular patient, if you would have chosen not to do a dynamic imaging modality like MRI, but if you've chosen for example, CT, where you acquire your imaging during diastole, you would not fully appreciate the discrepancy in size between the two branch PAs. So I think that's very important to realize. The other relationship, though, is that all these outcome studies from imaging studies in relationship with exercise performance is that pre-branch stenosis in itself does not appear to have a clear impact on exercise capacity, and probably that's related to the fact that the ipsilateral branch PA can probably at least partly accommodate the increased cardiac output during exercise, and therefore will limit the impact of the individual branch stenosis after the Lecompte. So in summary, you can appreciate a host of reasons which could have an impact on exercise reduction in switch patients. But from the papers and from the reports and literature, but also from our own institution's experience, is mostly the isolated cases of significant aortic insufficiency with either a moderate or severe AI that may have an impact on exercise capacity. But most of all, it's the MPA, and to probably less extent pre-branch stenosis that has an impact on an exercise capacity. And I think exercise testing is therefore required when patient is complaining of reduced exercise capacity in your clinic. That's something that you should trigger you to request exercise testing. Or your imaging is suggestive of MPA stenosis or other more indirect evidence of MPA stenosis with increased right-sided pressures. Thank you.
Thank you very much. It was a very good presentation. And now we are going to have Dr. Nico Blum. He is a professor of pediatric cardiology and the head of the Center for Congenital Heart Disease in Amsterdam, Leiden, in the Netherlands. His clinical expertise is in pediatric electrophysiology and interventional cardiology. He's going to talk to us about the fate of the coronary arteries and neo-aortic valve after the arterial switch operation. Thank you very much, Nico.
Thank you very much, Grace. I will share my screen. Is this okay?
Perfect.
Okay, thank you very much. So we stay in the Netherlands after Heinrich from Utrecht. This is Amsterdam, Leiden. I will focus this talk on the fate of the coronary arteries, less than and more on the neo-aortic route after arterial switch operation. Meryl already addressed coronary arteries a little bit. If you look at this slide, you can see that the survival after switch is actually, as we all know, excellent. On the left graph, you see the PCCC registry, where you can see that early mortality has dropped over the years to around a few percent in the late years, and also late mortality is very low. It's only a few percent during long-term follow-up. So that's clear that survival is excellent. So something's wrong here. And actually, even in the Netherlands, there is a Dutch competition player with the arterial switch operation. It was not Johan Cruijff on the left side. It is not Frankie de Jong. It's another player who will stay anonymous, but there is a switch player in the competition. So the survival is excellent, but there are residual problems. I will focus on the problems on the left side. And I think the most important topic, I think, is neo-aortic root dilatation, and related to that, aortic valve insufficiency. And of course, already addressed the coronary artery stenosis. And I think the big debate is whether the neo-aortic root dilatation, as we all know, that exists, is it progressive over time? And I think there are conflicting data. Some studies like this one by Aorta actually shows that the neo-aortic root growth is stabilizes after adulthood. And on the right, you see the data from Shepherd, from the Boston group, where you can see that neo-aortic root actually dilatation progresses after adulthood. And that's an important issue, because if it progresses, then that is not good news. If it stabilizes, it is good news. So what we did with our cohort in Leiden and Amsterdam with 345 patients, the earliest switch was in 1977. We measured actually serial echocardiographic images, measured 5 measurements per patient on average. We measured the annulus, the root, and the ST junction. And on the lower graphs, you can see the individual growth curves of these patients. And if you use spline statistics, you can actually create growth charts of the root and the annulus. And what you can see here on the left, and the annulus and the root, you can see that there's a steep increase in the first year of life, which is, I think, shown in many other studies. Then the growth of the root and the annulus grow proportionately, but then you can see after 20 years, actually growth continues, so it does not stop. And that our data show that quite clearly, actually. And if you look at growth in adulthood, so this is between 18 and 13 years. If you look at the aorta, the root of the annulus, the root, and the ST junction, you can see that per year, it's for the annulus 0.39 millimeters per year, for the root 0.63 millimeters per year, and for the ST junction 0.54 millimeters per year. If you compare that to a normal healthy adult, the aorta root grows a little bit, but it's only 0.08 millimeters per year. So this growth rate in adulthood is actually more or less comparable to aortopathies like Marfan disease and bicuspid aortic valve. What we showed is that complex TGA, which is the first two, the green bar and the red bar, actually is a risk factor for aortic root dilatation that has been shown in many other studies. What we did find was also found as an independent risk factor is that male gender is a risk factor. That was also shown in the Shepherd study. That's a relatively new finding. Other risk factors we could not identify but have been reported previously is pulmonary artery bending, arch anomalies, acute angulation of the arch, and size discrepancy of the great arteries. So if we look at neo-aortic valve insufficiency during follow-up, I think most studies show that almost half of the patients have some sort of aortic regurgitation, either trivial or mild, in the most cases 13 to 38%. Moderate regurg occurs in the series 5 to 15%, and severe regurg is relatively rare, 1 to 2%. But what we showed in the data from our hospital is that it is related to the root dilatation, and root diameter increase is actually the most important factor for regurg. And this from the Boston group, each millimeter per body surface area increase leads to a 5.2 fold increase of moderate regurg or more. And in our study, each millimeter increase gives a 9% increase in hazard ratio of moderate or more regurgitation. The other independent risk factor for regurg was complex TGA. We all know that reoperations for the aortic valve and the root are still relatively uncommon. But if you look at the growth chart, I think that is a matter of time, and that number will increase. I think Israel already discussed it a little bit, the mechanisms of root dilatation. What are the underlying mechanisms? Is it the vessel wall abnormality, so the the native pulmonary artery wall? Is it a geometry, or are there hemodynamic factors? Roel van der Palen, our young staff member, did 40 flow measurements to look at flow displacement and to look at wall shear stress of this neo-aorta, and found quite some striking things. In the lower graph, you see a normal flow of the aorta, which is concentric and laminar, but in the neo-aortic route of neo-aorta of a transposition patient, the flow is more eccentric, as you can see with the arrow, more eccentric towards right anterior. Here you can see it nicely in a reconstructed image, 4D flow image. Also in this neo-aortic route, the dilated route, you can see helices occur, which you don't find in the normal ascending aorta. So the flow is different. And he also looked at the peak wall shear stress, systolic wall shear stress. And what you can see in all the aortas is that overall the transposition patients have a higher wall shear stress in the entire aorta, in the ascending aorta arch and descending aorta, as compared to controls. The wall shear stress is also related to the root mid-aortic, mid-ascending aorta diameter ratio. So the wider the root, the more wall shear stress occurs. And what is important, you can see these red dots. That's the right anterior part of the aorta where the peak systolic wall shear stress is present in all the transposition patients, which is actually where this the area where the pulmonary branches scissor the aorta. So that is so I think flow, as I think Isra already mentioned, flow plays I think a role in this neo-aortic root dilatation. The other part of this talk, coronary artery obstruction after arterial switch operation, a lot has been addressed by Meryl already. We have to realize what the scale of the problem is. Is there a high risk of myocardial infarction and sudden cardiac death after the arterial switch operation? Actually, this first paper by Philip Bonhoeffer from the Necker group already mentioned, where they performed 165 routine coronary angiograms after switch operation, and that finding was quite shocking. Actually, they found 12 coronary occlusions, 8 major stenosis, 6 minor of the left ostium, and 4 stretching of 1 coronary artery. Obstruction were more frequent in the type D and E of the Jacob classification, but the numbers were quite impressive, and I think everyone was shocked by this publication at that time. Here you can see the type D and E classification according to Jacob. The type D actually is the most common variant from the Leiden convention, 1L2CXR. And actually all these coronary anomalies of variants are at risk for stenosis according to that publication. If you look at the series of Carey in 2013, it shows that the risk of late death, either sudden or due to myocardial infarction, is relatively low. It's 5 in 400 patients. So it's around, well, a bit more than 1%. And that's with a follow-up of 18.7 years. In that series, there were only 2 coronary interventions, and single coronary artery was a risk factor for adverse events. So the risk of sudden death in the entire cohort or myocardial infarction is relatively low, but it is present. And the Necker group, they did a lot of work on this, and they did a routine CTI in their patients and found 8.9 coronary artery stenosis, mostly of the left main. And if they found this on CTI, they performed a myocardial perfusion scan, and in total, 7 patients required surgery and 1 required a PTCA. But what they showed that the patients, the coronary artery anatomy that was risky for stenosis is if there is a more anterior position of your transferred LCA, so it's more at 12 o'clock or 1 o'clock, So that's a group that is at risk. If the CS is stretched, the CX is stretched behind the dilated aorta, neo-aorta, and if there is a high reimplantation, in this case, the right coronary artery, which the pulmonary artery can compress. And already addressed, and I think it's very true, that you don't know how this develops in time with the progression of the root dilatation. In Leiden, in adult patients, we performed a smaller study, 13 consecutive adult patients underwent a routine CT angio, and most of them, 80%, had normal anatomy, 70% had the 2CXR, one 2CXR, and 3 had the more different variant. And what they found was that the very acute angle, as you can see here in the picture, and that is defined as less than 30%, was more frequent if you have a variant coronary anatomy. In this whole series, there was only one patient who had a significant stenosis in the variant stenosis group, but the acute angled coronary origin was present in 4 of the 6 variant anatomies. And this acute angle, and also shown in the paper, in the French paper, I think that if the root further dilates, that can cause compression. The last slide on coronary events is a multi-center European study where they looked at a large cohort of transposition patients and looked at the coronary events in that group. 476 patients had the normal LCX2R anatomy or the L1L2RCX anatomy, and 139 patients had the more complex anatomy. And as you see that, although it does occur in that normal anatomy group, or the most common variant, the risk of coronary events is very low if you look at this graph, and that the coronary events really occur much more, up to 13% in the ones with a complex anatomy. So to conclude this talk, neo-aortic root dilatation is progressive over time, so that's a very important finding. I think there's no stabilization in adulthood, and we could clearly show that progressive root dilatation is a critical factor for valve function. Flow plays a role. There's flow displacement and increased wall shear stress that could play a role in progressive root dilatation. We know that reoperation rate on the new aorta is very low, but we expect that there will be more reoperations if patients grow older. Then the question, I think, already addressed by some of the speakers, how you should evaluate your coronary arteries. I think you should do routine coronary artery evaluation despite the relatively low risk of sudden cardiac death and myocardial infarction. But as shown, CTA is very easy. It's fast, accurate, low dose radiation. And what we do not know is how coronary artery problems develop in this aging switch population. What we do is, what you can do is, after your CTA is abnormal, you can do further diagnostics like myocardial perfusion scans, angiograms, or coronary flow reserve testing. And then it was a question already asked in the question and answer session I saw, when should you do these evaluation? Well, this is what we usually do. If there is complex CA anatomy, we do it in the early post-op phase already in patients who had complex anatomy, or in cases where there have been perioperative problems, LV dysfunction or symptoms. And we do it, probably other centers do it in another fashion. We do it routinely in all cases around the first decade, and we repeat it during long-term follow-up. I think it's important to evaluate changes of these coronary artery angles during growth and new aortic dilatation. And in case you doubt on your CT scan or it's unclear, you have to do further diagnostics. So thank you very much for your attention. This is not this is a sun, and it's actually a kite, which you can see here. It's not a moon. Thank you very much. I give the screen back.
Thank you, Nico. It was a very nice presentation. Can you just do us a favor? Can you pronounce correctly the last name of Hendrik so we can see how
Oh, it's
wrong
very
Gil
easy.
was?
It's Grotenhuis.
Almost the same. Gil, you did it right.
I think Gil did a great job there. Yeah.
Yeah. This G from the Dutch language is something that only
It's
them
G.
can
It's
say
G.
it.
The Germans also find it very difficult to pronounce the G. Yeah.
Yeah, it's very, very difficult. Okay, thank you very much. Now we are going to have some discussion, some questions for the audience. Nico, if you can just stop sharing your screen.
Yeah,
Sasha is going to launch the first poll. We want to know who you are. Sasha, can you launch the first one? Okay, so if you can please answer, where are you from? And as we could see on the question and answers, all of these talks were very helpful for everybody, including me. I've learned a lot. Thank you, guys. Amazing. So we have, as usual, most of people from Latin America, then Asia falling. This is very nice. This is very nice. That's the first time that we have so many people from Asia. We are very happy to have all of you.
Midnight, Grace. It must be midnight there. So thank you.
Yeah, thank you very much, guys. Yeah, we are happy for that. Okay, the second one, Sasha, please. And who you are, how you describe yourself. So we usually have most of people as pediatric cardiologists. Let's see this time. Yeah, the same, pediatric cardiologist, half of the audience, but this is very nice that we have cardiac surgeon and intensive care people, even neonatologists. And Alaya Health and nurses are becoming more frequent. We are happy for that as well. Okay, so we have 2 questions about what you do on your current practice. Can you launch that? Okay. So how many arterial switches do you perform, do you follow up on your clinic if you are a pediatric cardiologist? Yeah, a great amount. And 21% has more than 30 patients that they follow up. But this is nice. Okay, and the next one, last one for this part. So how about the center that you work for, and how many ASO are performed every year? Yeah, I can say that it's a very reasonable amount, but it's interesting that 10% don't do ASOs in their centers. Would be nice if you could write on the chat why you don't perform ASO on your center. Would be a very nice thing for us to know. I'm going to share my screen for a moment. I want to show you the next activities of Congenital Heart Academy. So, and please follow us on social media. This is very important to us and as the best way so we can get close to you. And we are going to send you by email, and it's on the chat box as well. But we want to know what you are thinking about this meeting. So please, when it's finished, fill the survey for our feedback. This is going to be very important for us to move on. So the next big webinar is going to be next Thursday on the same time. It's going to be the second part of the ECMO talk. The first one was very nice. We had almost 2,000 people attending, and it was a very happy and enthusiastic. And we for sure we are going to have the same thing on the second part, and just showing that we have as a keynote speaker on this time, Dr. Bartlett. We are very proud to have him with us. And we are going to have on, here. So tomorrow we are going to have a very nice talk with Dr. Anderson. This is going to be about morphology of the AVSD. So we want all of you to join us tomorrow to discuss directly with Dr. Anderson about this. Then we are, and this is going to be a series as well. We started with TG with a fellow, ASD, AVSD, VSD, and then we hope we are able to continue with this series on Fridays with Dr. Anderson. And we are very happy to announce that Dr. Meryl Cohen is going to have a series with us as well to discuss closely the echo with all of these topics. And if you have an interesting case on that topics that you want to show on that presentation and discuss with Dr. Meryl, please send us an email, and we are going to be happy to have you to present your interesting case and to discuss with her. And
Grace,
we have.
Grace, are these going to be live? Are Professor Anderson and Professor Cohen's series going to be live on the YouTube channel as well as on the webinar?
Yes, yes, everything is going to be live on YouTube. Only we are not sure about Dr. Silverman. This is the only one we don't know. Sasha, we have any news about this? If Dr. Silverman is going to be able to be live on YouTube?
I don't believe it, because at the moment he's working on copyright, because he's a part of video book is building.
Yeah. Yeah, so but all the other activities are going to be available live on YouTube, and then for you to watch again or share with your colleagues later on our YouTube channel. So we are very happy to have Dr. Meryl in this ECHO series, and everybody's welcome to join and to send your cases so we can discuss together. And then we are going to have continue the series with Dr. Silverman. The first one was about truncus. It was very nice. The images were amazing. And now we are going to have transposition, AVSD, and VSD with him as well. We are going to receive all of this information on your email, and the link for the first ones are on your chat box as well. So I'm going to stop to share my screen, and then we are going to have some questions about the talks that we just had. Sasha, can you launch the first tool? Okay, Laura, are you there?
Yes, Grace, shall I read the question then?
Yes, please.
An 8-year-old girl is followed after arterial switch operation. She's been fatigued since starting kindergarten. She has a normal saturation, blood pressure, and she's had normal growth. She's developed a long systolic murmur that radiates to the left axilla that's gotten louder as she grows. Echo was difficult to visualize branch pulmonary arteries and the ascending aorta. What is the next best test? This is not a board's question.
This is nice to see the practice and see if you're able to make people's mind with your presentation. Okay, can you comment on that, Laura?
Again, I read Echo, MR, and CT, and I love all three modalities. I also agree with the 97% of people who chose cardiac MR. It is unconstrained by thoracic acoustic windows. You can see it is easy to apply in many patients. Can actually do it without sedation down to a younger age in many centers, down to at least age 8, sometimes younger. And it gives you very detailed imaging of both the left and right ventricular outflow tracts, the entire chest. And in addition can give you pulmonary artery flow distribution if you're suspicious of a significant pulmonary stenosis that affects how much blood gets to each lung. So I happen to agree with this. Thank you.
Very nice. Just one quick reminder, this is the half of our webinar. We see a lot of thank you on the chat. If you're able to stay, we have a lot of interesting talks after this first part. So please keep with us, stay with us if you're able to. Very nice. Sasha, the next one. Nico, it's yours.
Yeah,
is Nico
that's
there?
mine. Yeah, I'm here.
Okay, can you read it to the audience?
Yeah, which
so
statement regarding new-aortic root dilatation after the arterial switch operation is not correct? So it's one is new-aortic root dilatation is associated with the incidence of aortic valve regurg. Male gender, complex anatomy are independent risk factors for root dilatation. Aortic root growth rate after switch is similar to the aortic growth rate in aortopathies like Marfan syndrome. Progression of the new aortic root stabilizes in the second decade. Probably they all know the answer now. No, not all.
Okay, can you comment on that?
The correct answer is it's not correct. So it does not stabilize in the second decade, and it continues to grow after the age of 18, so after childhood in adulthood. So maybe the question was a bit misleading with not correct and correct. So that might be the reason that the other answers are filled in.
Great. The next one, Sasha. Meryl, that's yours.
So which of the following is a risk factor for coronary artery complications after the arterial switch? VSD, coronary artery revision during the arterial switch, neo-aortic valve regurgitation, or pulmonary hypertension? Fortunately, most people got the right answer, which is coronary artery revision after the arterial switch. It seems that if the surgeon has trouble translocating the coronaries during the initial procedure, that translates to issues or concerns later on. And in many of the studies of follow-up using CT and MR, it was noted that the patients who had coronary artery narrowing or atresia had trouble at the arterial switch, and that is one of the risk factors, along with an anterior coronary, as Nico discussed, and likely intramural coronaries.
Very nice. Isra?
Okay, so what's the best imaging modality for 3D printing and virtual reality? Is it contrast-enhanced MRI, but non-ECG gated, such as angiography? It is 3D balanced SSFP magnetic resonance imaging, which is an ECG gated sequence. It's computed tomography, if you can do it gated and not with too much radiation. Or it's the imaging modality, which my center has better expertise.
And do you know how available this technology is around the world, especially the virtual reality?
I mean, virtual reality, what you have seen, they are glasses that a teenager use for playing video games. So the cost is only 600 euros, or let's say $600. So it's not really expensive. And all the software that we use is open source software, because that's one of the key, which is making this technology available for everybody all over the world. And also the 3D printers that we use is FDM technology. The cost is also something like 500, 600 pounds, dollars for the printer. And the cost of the 3D print model using a polyurethane, it's only $20. So it's not really expensive if you move far away from the commercial companies.
Okay, we are going to propose for you a how I do it session so you can teach everybody how we can do it by ourselves.
It will be my pleasure. So I can see that most of you, some of them use CT, MRI. After we lead one of the biggest studies about a 3D printer where every single center send us the images, what we just realize is what you are good doing, keep on doing. So if you are very good doing CT, even though I was trained that CT is the dark side of the force, you shouldn't do it because it's just only MRI. No, do CT. The quality of the image that people send all over the world doing CT, if they have expertise, is fantastic. And that's what you really need to do a perfect plan surgery. Although I will suggest that everybody will try to use MRI, particularly the second option, which is the 3D balance MRI. And why that? Because with the balance SSFP, you can choose either the systole or diastole. What we found is, for example, for stenting, you really need to capture the pulmonary arteries in the largest diameter, so go for systole. However, for BSDs, it's better to go to diastole because it's where the heart, it's more relaxed and the size of the BSD is larger. So depending on the technique or the kind of surgery you are planning, one technique or the other may be better. But anyway, and also with 3D echo, it's fantastic what people is providing us about quality. It's really, really, really good. So if you are good doing 3D echo, keep on doing 3D echo and we can print from your data.
This is impressive that we can use any modality of image. Okay, I think that was the last poll that we have for now. Unfortunately, we won't have time to make live questions, but we can continue in Q&A, and then we can make some live questions in the end of the session if it's okay for everybody. Okay.
Grace, I
wanted
to remind the panelists there are a few specific questions for you in the Q&A box when you have time to answer them. And thank you all for answering them promptly and for everyone for being here. Dr. Agati.
Okay, thank you very much. It's time to introduce Dr. Lee Benson. As Dr. Zahn told last week, you don't need too much presentation, but I think it's important to share with all of you that after his training in Toronto, Philadelphia, and Los Angeles, in 1983, Dr. Benson joined the clinical staff at the Hospital for Sick Children in Toronto as director of the Variety Cardiac Catheterization Laboratories. In 2007, the laboratories facilities were redeveloped as the Mitchell Goldar Cardiac Diagnostic and Interventional Unit. Dr. Benson developed the interventional program in cardiac catheterization at the Hospital for Sick Children, which today is one of the largest programs in North America. He is, of course, full professor of pediatrics and cardiology from 1992 and is co-author and author for over 375 original articles. He received the Career Achievement Award in 2001 from PICS and IACS conference. So it's my enormous pleasure to give the words and give the video to Professor Lee Benson.
Okay, thank you. Let's see.
You have to close your microphone.
Oh, I'm trying to answer some questions. I apologize.
Okay, can you see my screen?
Yes, perfect.
Yeah, thank you for the kind words and the opportunity to participate in the Academy with this very distinguished faculty. I'm learning quite a bit. And happy to discuss catheter interventions after the arterial switch repair. No disclosures. As we all know, the essential components of the arterial switch operation is translocation of the main pulmonary artery using a Lecompte maneuver and the aorta, and transfer of the coronary arteries to the neo-aorta. And as we've heard, while the long-term results of the switch are generally excellent, and complications in this era are relatively rare, one can anticipate where complications can occur, the aortic arch, branch pulmonary arteries, and the right ventricular outflow tract. And we've heard about coronary artery complications, and later in life, the issues of neo-aortic regurgitation and aortic dilation. A paper not too long ago looking at the incidence of reoperations and percutaneous interventions in a large cohort of switch patients over a several decades experience identified about 4% of the survivors requiring some form of intervention. We could see here the majority being in the pulmonary artery, and of course, in patients with aortic arch anomalies, an incidence of recurrent coarctation. The risk factors for intervention being a main pulmonary artery reconstruction with patch material or an aortic arch anomaly at diagnosis. So on the left panel, that's the sort of the angiogram and the appearance of the pulmonary arteries that we'd like to see in all our patients after the switch operation, and some imaging showing the relationship of the branch arteries that we've seen earlier from the earlier discussions, and how the pulmonary arteries sit straddling the aortic root. Unfortunately, one can identify as well compromise of the dimensions of the branch pulmonary arteries. And in this three-dimensional model, just to give you a notion of what these branches look like in a three-dimensional model, to give you a notion of what kinds of forces are acting on the right ventricle and the branch pulmonary arteries. There's a spectrum of obstructive lesions on the right side, from minor or mild branch pulmonary artery hypoplasia or supravalve stenosis to significant pulmonary valve and right ventricular outflow tract hypoplasia and stenosis, and compression anteriorly from the sternum and posteriorly from the aortic root. We've seen patients who've had discrepancy of branch pulmonary arteries, which can be mild, or in this case, quite severe after repair. And of course, the effect of the posterior aorta on the right ventricular outflow tract resulting in obstruction. So what are the indications for intervention? Early post-op, patients with low cardiac output syndrome, right heart failure, with anatomical, either CT, echo, evidence of an obstructive lesion, or Doppler evidence of significant flow discrepancy and obstruction. Regardless of the gradient, a maneuver in the catheter laboratory can be life-saving. If the child is hemodynamically stable, there's a tendency, certainly in our unit, to defer any percutaneous interventions for 3 months or longer, allowing the suture lines to mature. And of course, it's dependent on the location, the mechanism of the obstruction, and additional factors such as the right ventricular pressure estimated by echo, or the RV aortic pressure ratio, or the left-right flow distribution, which can be obtained from accurately from MR imaging. And of course, the symptom status all factors into the clinical equation of whether or not the patient, or the timing of the patient's intervention. And for the interventional cardiologist, the boundary conditions that we use for balloon or stent application to the pulmonary arteries, the stent diameters, for example, are the same as that for isolated branch pulmonary stenosis. The available tools that we have early post-op, primarily standard and high pressure balloons, cutting balloons, and in the rare case, we have employed coronary artery stents to deal with significant branch pulmonary artery stenosis, recognizing their limitation in dilation potential. And I'll address that in a moment. In the older child, the armamentarium is a little bit broader. We have the availability of larger stents, whether they're covered or bare metal. And there have been instances of percutaneous valves implanted in the outflow tract of the transposition population under the right clinical need. There was a study not too long ago from Nellis in Iowa looking at 103 patients who've had the switch procedure, and of 29 patients that required some form of intervention, 15 were percutaneous, mostly balloon dilation, 3 stent applications. What was interesting from this study, and I think from our experience as well, is that patients who undergo intervention on the left pulmonary artery or the main pulmonary artery frequently are in a cycle of recurrent intervention, and main pulmonary artery interventions tend to be failures in the long term. And that's probably due to limitations in the sizes of the balloons that we can use, compression of the right ventricular outflow tract, whether that's anterior or posterior from the in the mediastinum, and bifurcation stenosis limiting balloon size. There are some techniques that have been described. This is from Oliver Stomper in Birmingham, of ways to stent bifurcation stenosis, which have been applied in the transposition population in selected instances. So this is an example of a patient that we took care of. This is the appearance of the right ventricular outflow tract and confluent branch pulmonary arteries, but stenosis at the distal end. The confluence, there was also left pulmonary artery stenosis, as you can see here. We undertook bilateral pulmonary artery angioplasties in this patient, and the final outcome in this angled caudal RAO projection is very satisfactory, both anatomically and hemodynamically. Unfortunately, the patient went on to other interventions, subsequently had stents placed over the years, and you can see here that the stent has developed some in-stent stenosis, not uncommon in this population. And before the intervention on that stent, as alluded to by Meryl's talk, the coronary arteries are in close approximation to the branch pulmonary arteries. And in this case, the left coronary artery was felt to be distant from the left stent and allowed us to do a dilation safely. But to any interventionalist who's planning on intervening on the branch pulmonary arteries in this anatomic setting, it's necessary to locate the origin of the left coronary artery in relationship to the left pulmonary artery before any intervention. And the same is applied to the right side. This patient subsequently was dilated, and you can see the improvement in the flow distribution to the branch vessels and the appearance of the ascending aorta and the coronary arteries post-intervention. Again, another model from a different patient looking at the relationship of the branch pulmonary arteries and the aorta, the striking importance of understanding the location of the coronary arteries in relationship to the branch vessels is very important. And I have to say, I think in general, the left pulmonary artery tends to be more affected by obstruction or stenosis than the right in terms of frequency. So what are some other considerations about percutaneous management strategies? Well, in the small child, in the infant, stent deployment is, we try to avoid it because of patient size. As I alluded to earlier, surgery, or early after surgery, coronary stents may be required, and they may be life-saving with very severe bilateral pulmonary artery stenosis and hypoplasia. We try to use coronary stents to have an expansion potential, but they're limited use only if the patient is hemodynamically unstable. There is a strategy in smaller children that seems reasonable to use balloon angioplasty as a bridge, if you will, to procedures when the child is a larger size, and you can palliate, if you will, the hemodynamic issues. So this is a patient who had a Lecompte maneuver, had coronary stents implanted because child was very, very sick postoperatively. Now the child is coming back for further intervention and assessment. You can see the left pulmonary artery distal to the coronary stent has developed a stenosis, in partly related to the dilation of the stent itself. We undertook balloon dilation of that stent and was able to enlarge the stent diameter as well as address the distal lesion. Unfortunately, we did have to deal with the right pulmonary artery stent as well. This was the appearance prior to intervention. We undertook a high pressure balloon angioplasty, as you can see in the middle image, and then the result afterwards. So one can achieve some improvement even with coronary artery stents. And in this particular patient, came back some years later. And this is the appearance of the ascending aorta with the stents straddling the branch, the pulmonary artery branches straddling the aorta, and the location of the coronary arteries. But this child also had RVOT obstruction and had a covered stent implanted in the right ventricular outflow tract, and one can see the improvement in forward flow. There are complications. Lord knows there's complications to everything we do. This is a young child shortly after surgery, and the angiography demonstrated reasonable flow, mild stenosis of the left pulmonary artery, but a significant supravalve aortic stenosis. This child went to have surgical revision, but came back some years later for reassessment of the left pulmonary artery, and had a balloon dilation of the left pulmonary artery with some improvement, but the child became unstable at the time of the catheterization, and this is the result. You can see with the aortic root injection, there's filling of the branch pulmonary arteries because of the development of a traumatic AP window, which occurred after this catheterization. This child went to surgery, but today, this was a number of years ago, today, this occurrence would be addressed with a covered stent, develop the aneurysm. The risks of this developing in this setting are the use of bare metal stents as prior implantations, redilation of stents to larger than rated dimensions, and if there's a stent fracture pre-existing before the dilation. So some general comments on the risks related to pulmonary artery interventions in general. Most studies have demonstrated that there's a low morbidity and mortality from the Congenital Cardiac Catheterization Project on outcomes. MACE, or death rate from pulmonary artery intervention, about 3%. Impact registry shows MACE and death rate about the same at 2%, but slightly higher in newborns under 4 kilos, single ventricle patients, and emergent procedures. The risks of pulmonary artery interventions are slightly increased. A recent study from San Diego looked at pulmonary artery interventions after the arterial switch, and in their experience, which included 3 instances of traumatic fistulas, the MACE and death rate was approximately 14%. And they emphasized, as I do, the importance of coronary compression testing prior to any pulmonary artery intervention in this setting. Of course, there's other lesions that are acquired. Patients, particularly if they've had aortic arch anomalies associated with their transposition, can have recurrence of their obstruction, and this can be addressed, a coarctation, this could be addressed by balloon dilation in the younger child, or coarctation stenting in the older patient. Patients with supravalve aortic stenosis remains a surgical lesion, although there is a recent publication looking at a very highly selected population of individuals with high morbidity and comorbidity features that a percutaneous approach to stenting with bare metal stents was achieved effectively. And arch stenting has become a little bit more applicable with enhanced imaging for stent implantation and location during the procedures. There's been a discussion about coronary artery complications. Again, when one identifies them with significant symptomatology, it's a surgical lesion in the child. PCI has been reported in transpositions in the early years in applications, particularly from the French group, but it's not a standard of care for a young population overall. I show this angiogram. This was a teenager who had chest pain on exercise, very convincing. We brought her to the catheter laboratory. The aortic root shot, you can see filling of a dominant right coronary artery circulation and sluggish filling of her left. Selective angiography in the left coronary artery demonstrated high anterior takeoff of the coronary artery, which was alluded to by Miro's discussion as a potential risk factor for compromise. We did FFR and IVUS and were unable to demonstrate any compromise to flow in this young woman, and this was not treated now many years into her clinical course. But it is important to take in consideration the location of the buttons and how they interact in the dynamics of the cardiac cycle, as is seen in this panel, where you can see the origin, particularly the left coronary artery, can potentially become compromised during exercise. So in conclusion, fortunately, the incidence of pulmonary artery, arch, and coronary compromise is low, but it's not zero. Percutaneous interventions are effective for branch pulmonary artery stenosis, but there is an increased incidence of reinterventions on these lesions. It's not one-stop shopping. Effectiveness of the intervention on the RVOT is entirely dependent on the details of the morphology and the obstruction. And as I mentioned earlier, supravalve AS and significant RVOT obstruction are best treated surgically. So with that, thank you very much.
Thank you, Lee. It was amazing. I think that we, as a surgeon, will learn a lot, and we learn every day from what the interventional cardiologists can do for this, as Gil say, maneuver of Lecompte. Probably we have to reconsider this or think from this different point of view. But now it's again the opportunity to share the experience now, firstly from Italy with Vladimiro Vida, who is the Chief of Pediatric Cardiac Surgery in Padua. And rather than on the right side, he will tell us what is the follow-up, what is the destiny, the fate of the left heart obstruction after arterial switch operation. So Vladimiro, welcome in Congenital Heart Academy, and please share your screen. Thank you. And open your microphone. We cannot hear.
Sorry, can you hear me now?
Yeah,
okay.
Yes.
So Sasha, I would like
Perfect.
to thank
Thanks.
you, Gil and Grace, for this invitation and for this great opportunity to be part of your academy for this webinar. So my topic will be discussing what happened on the left side of the heart following arterial switch operation. I have nothing to disclose. So the arterial switch operation has become the gold standard since decades for managing patients with detransposition of the great artery and double outlet right ventricles. Starting with a little bit about our experience, we had the chance to review recently what we did in the last 30 years, and we treated almost 267 patients, mainly with simple, but only 1/3 with the complex transposition, including VSD, LVOT, and coartation, excluding for this series where transposition treated with other types of repair, like Rastelli and Nikaido. And what we saw is that the operative mortality is almost standardized with other paper present in the literature, stating that the current operative mortality is around 5%, which is 3% in the simple form and 11% in more complex form where you have to do more. And interesting, we saw, and it's something that is very interesting also in other paper, that the mortality is not is unrelated with the type of coronary artery anatomy, which in the past has been identified as a risk factor for the survival in after arterial switch operation. After a median follow-up of 10 years, we had also some late death, 0.8%, like Professor Blum said, is infrequent, but may happen. And both were sudden death. So the survival is actually pretty good with transposition, 94% at 5 years, 10 years, and 93% at 20 years. But after more than 40 years since the first switch operation, we are now having the chance to see what happened on the right side and also on the left heart structure that are involved in the correction. And it's now clear that a certain percentage of person can go to further reintervention or reoperation. It's been clarified by the previous speaker that the vast majority of the reoperation or intervention and on the right side of the heart, where the new pulmonary stenosis, mainly at the origin of the branches, can be present, and is following what is the Lecompte maneuver. So our maneuver to prevent this problem is to mobilize extensively the pulmonary artery branches, since after the operation they have to prolong their course. But there are problems in patients with complex transposition and in problem with DORV, tetralogy of transposition type, because this problem can be more present. But less is known about the frequency type and outcome of reoperation after arterial switch operation on the left side of the heart. And these, namely coronary ischemia, aortic root dilatation, aortic insufficiency, and left ventricular outflow tract obstruction. My previous collaborators here during the webinar already talked about which are the risk factor for developing all these recurrent problems after arterial switch operation. But regarding the coronary ischemia, actually the main problem, which is more frequent in patients with coronary anomalies, is that we can have a distortion of the coronary course in the first tract, and this is mainly related to the technique of implantation. Usually, if you have patient with single coronary artery of intramural coronary artery, the problem is more frequent. But also you can have compression from the Lecompte maneuver. So patient with complex transposition, patient with DORV, where the translocation can be more difficult because it's not an anterior posterior translocation, but is a side-to-side transplantation of the coronary, can lead to distortion, and this distortion can be magnified by the time after the arterial switch operation, and this may lead to what is called the silent ischemia. We are doing a multi-center European study on that, and I don't have the preliminary result with me now. The problem is not so frequent, but is present. And these risk factors for coronary ischemia are, of course, the basic coronary anatomy at the time of the arterial switch. These not include the right from the circumflex from the right, but mainly major coronary artery anomalies. But also, we assisted also on an intimal proliferation and the progressive compression by aortic root dilatation, because in many of these patients, as Professor Blum said, there is a progressive dilatation of the aortic root, which does not stabilize with age. This is an interesting case we had. Is a case of a patient who underwent an arterial switch operation, which was complicated by a damage, an iatrogenic damage of the coronary artery of the left main during the isolation of the coronary bottom. And this patient was not diagnosed to have an intramural course. So at the time of the switch, we did an emergent CABG with the left main, the memory on the anterior descending. This was enough to bring the patient out of the OR and to stabilize him till discharge. But during the follow-up, what we noticed that, he was still asymptomatic, the ventricular function was good, he had no sign of ischemia, but at the SPECT MPI, he had decreased perfusion of the basal anterior segmental LV. And the coronary angiography, he has no occluded CABGs, he has a severe LCA ostial stenosis, but he had, fortunately, an important intercoronary circulation. That means that the right coronary was the single coronary for this kid. So what to do in this kid? This is a question mark. But this is one of the patients we need to face in the next future. So regarding the aortic root dilatation, well, the majority of patients with arterial switch operation had some form of dilatation of the aortic root. This is mainly related to the fact that sometimes, mainly in patients with VSD and mainly in patients who had a late surgery, there is a discrepancy also with the size of the proximal aorta and the distal aorta. Rarely, reported in the literature, this dilatation goes more than 45 millimeters. And even if the dilatation is very fast during the first year after the arterial switch operation, there is a big question mark, but has been partially solved. But what Professor Blum said, that there is no stabilization. There is a decrease of the progression, but no stabilization. So it means that the aortic root continue to grow. This is a problem we needed to take into account, because it's one of the main problems we need to face in the near future. So other causes related to the aortic root dilatation, apart, the ventricular septal defect, the mismatch in patients with a bigger aorta than the pulmonary artery, mainly in patients with complex transposition, is the geometry of the aortic root, the presence of and the use now has been more abandoned of pulmonary banding, and also of the coronary reimplantation techniques. Sometimes when we have a difficult reimplantation, what we do is the trapdoor. So mean that we open a little door on the aortic root just to favor a less rotation of the coronary artery from the anterior position to the posterior position. This means that you favor to the reimplantation, but you also favor that you increase the diameter of the proximal aorta. And this means that you have a bigger aorta to anastomose to a smaller distal aorta. So it means that this is a prognostic factor for a future dilation. But with this question in mind, we embarked, I'm part of the European Congenital Surgery Association, we embarked on a multicentric study focused on the reoperation after arterial position on the left side of the heart. And we define left-sided reoperation any surgical procedure that was necessary for residual or new anatomic or functional problem after a previous arterial switch operation, mainly focusing on the aortic valve, aortic root, and coronary artery, including also the left ventricular outflow tract. And we were able to collect from 17 European centers data on this. We included all switch operation, either simple and complex, and also we added the DRV TGA type in a period extending from 1975 to 2010. And we excluded patients who underwent other forms of repair other than arterial switch operation and reoperation on the aortic valve and aortic isthmus. The population we were able to collect was composed of about 111 patients, actually saying that the reoperation on the left side of the heart after arterial operation is a quite rare event, because they represent the 1.5% over the 7,951 arterial stitch operation followed in that period of time. Mainly, he was present in transposition, mainly because also a transposition were represent the bigger number of patients in our series, but there are also patients with dual VTGA type. Going to the indications, what we noted that the main indication was represented by isolated neo-aortic valve insufficiency, coronary problems, recurrent left ventricular outflow tract obstruction. I have to say that 10 of these 17 patients had the LVOT surgery during at the time of the arterial stitch operation. And then we have combined aortic root dilatation and neo-aortic valve insufficiency, supravalvular aortic stenosis, and other less common forms. Regarding the indication, sorry, I have to go back. Regarding the indication, the vast majority of the patient had some form of neo-aortic valve insufficiency, but it was moderate to severe in 50% of this patient, since, as I said, the isolated neo-aortic valve insufficiency was the most frequent cause. Regarding the aortic annulus, it was a little dilated, going to reaching the z-score of median z-score of 3.9. But what we noticed that the main dilated thing was represented by the aortic sinuses, reaching the 46 millimeter and the 50 millimeter in dual VTGA types. So it means the dual VTGA types have a much bigger indication for replacing the ascending aorta. Regarding the procedure, there were 126 procedures in 111 patients, mainly represented by aortic valve replacement. All of them were mechanical aortic valve replacement, LVOT relief, and this was done by relieving any accessory muscle or fibrous tissue below the pulmonary valve. In 13% of patients, they were able to save the pulmonary valve, the aortic valve, by just plastic the aortic valve. And in 21 patients, there were a mix between solving the coronary artery problem by coronary artery relocation. This is because there was a distortion of the first part of the coronary course. This was distorted by the dilation of the aortic root, and in half of the patient, a CABG was necessary to solve the coronary obstruction, since a relocation was not possible. Other 10% on patient, they call a Bantal procedure, means that they changed the aortic valve and the aortic root, and also there were patients solving the supravalvular aortic enlargement by plasty, reducing the redundant part. We had a switchback operation, means that the switch operation was putting back the pulmonary valve in aortic position, and other less common forms. In 17 of these patients, we had associated procedure on the right side. Since we focus on the left side, all these patients have the left side procedure, but mainly since we are on the site, we just also proceed for plasty, the pulmonary branches, RVOT resection, and also other less common forms. I have to say that, and this is specified in my few last slides, the access to the aortic valve in switches is very difficult. It's very difficult. And this is important mainly for cardiologists, because at the time you re-enter in the chest, you're facing with a stretched pulmonary artery in front of the aorta. And to have access to the aorta, you need to detach the Lecompte maneuver. You have to take down the Lecompte maneuver in a certain way. And sometimes it's not difficult, it's very difficult to get it back. But focusing again on the reoperations on the left side, actually the mortality is pretty high. Usually the mortality for a right-sided operation is pretty low, it's less than 1% according to the European Heart Surgeon database. but on the left side is pretty low, is pretty high, 6%. I have to remember that the average mortality for patient in cardiac surgery center is between 2 and 3%, but 6.6 is more than double the average mortality. And the mortality was higher in patients with D or VTGA type, and the main cause of mortality was low output syndrome. Most of the patients had low output syndrome, most because the majority of them had coronary artery problem, reduced ventricular function, so they were patient at risk for reoperation. After the left side of the operation, we had also the chance to follow all these 111 patients, and what we notice is that the left side of the operation is not an isolated fact, because 16% of these patients need another reoperation. 2 of them required also a orthotopic heart transplantation. So it means that the problem is rare, but is present, and is something that is increasing, and we have to face off in the near future. The mortality, the hospital mortality up at the time of left side operation is pretty high, but we also have a late mortality. 2 of these patients died at secondary operation. So it means that all of these patients have some form of left ventricular impairment, and a couple of them have coronary artery problems. Since that left side of the operation is not an isolated problem, it's a mixed problem, mainly including also the coronary artery, where the mechanism is not only the reimplantation, but also following the dilatation of the aortic root, so it's an associated problem. So what we concluded from this study, and as a conclusion of my talk, is that the incidence of reoperation, what we noted is quite rare at the moment, is 1.5%, and mainly is required for new aortic valve insufficiency and coronary artery malperfusion ischemia. Patients with coronary artery problem need to be treated or conservatively or by revascularization. And it's important that being conservative is the most important thing. What we found also that there is a kind of recurrent left ventricular outflow tract obstruction, since the majority of patients that have a recurrent LVOT were operated at the first operation for LVOT obstruction. And we believe this is not an anatomic problem, but it's a more technical issue. The majority of these patients are also a VSD closure, and mainly a scarring tissue at the level of VSD can contribute to a recurrent LVOT obstruction. So the mortality is not negligible. Mainly is for left ventricular low output syndrome, means that this patient can have also associated coronary problem, and this means that most of them have a decreased function of the left ventricle. That means that have an increased risk at the time of the operation. Some of the patients need also a secondary operation, mainly patients with URV-TAGA type, and also a late mortality has to be contemplated, because this is an important problem need to be faced off. So what an inference has said that going back into an arterial switch operation, either on the right, but mainly on the left side, is a technical challenge, is a very difficult technical challenge. Sometimes when you take down the Lecompte maneuver, either take down one branch or take down one the main pulmonary artery, sometimes the left LPA or RPA falling apart, and there is no issue to bring them back. So you need to add prosthetic material. In this case, is a patient that I reoperated a couple of weeks ago for left ventricular outflow tract obstruction that was not present at the time of the arterial switch operation. He underwent a successful switch operation for a simple TGA, and then he developed after 18 months left ventricular outflow tract obstruction. Here you can see at the top there is a head of the patient, at the bottom the foot of the patient. Here is the celastic, the white stripes here are encircling the left and the right pulmonary artery. So I took down the MPA and I bring over toward the head of the patient. So in this way, I have the chance to have access to the aortic root. And also, I have to say that the point of contact between the main pulmonary artery and the aortic root is very fragile, and the aorta is very, very thin. So sometimes this is also another technical issue to take into consideration when you go back into an arterial switch operation. So I have to I finish here my talk. I have to thank again the Academy for the invitation, and I hope that my presentation was quite clear and to give information and more details to the talk. Okay, thank you very much.
Thank you so much, Vlad. And congratulations on getting 17 centers to collaborate in one of the largest studies in the literature now. Certainly the largest on that particular topic. And I thought that was terrific, and the pictures were wonderful. We're going to move to from reinterventions, mortality, surgery, to important factors related to quality of life. There's a quote that the brain is the most important organ, but of course that's according to the brain. And I'm happy to introduce Dr. Shabnam Pevandi, who is one of the world's experts for sure in looking at neurodevelopmental challenges that some of our patients face. She works at the Benoff Children's Hospitals as part of the University of California in San Francisco. And I'll turn the screen sharing over to you, Shab.
Thank you, Gil. Can you guys see my screen?
Yep, it's perfect.
Okay, great. Thank you, Gil, Grace, and Sasha for inviting me to this wonderful webinar. So as Gil mentioned, we're going to be switching gears and talking about neurodevelopmental outcomes in patients with transposition of the great arteries. And I find it helpful to think about a lesion like transposition in the context of other forms of neonatal congenital heart disease, like hypoplastic left heart syndrome, where in one group you have a corrective operation with restoration of normal physiology. And in the other group, in HLHS, you have a palliative approach with ongoing abnormal physiology. So this is data that I pulled from our center here in San Francisco over the last several years, looking at early childhood cognitive outcomes. And compared to normal children, children with hypoplastic left heart syndrome have cognitive outcomes that are almost one standard deviation below normal, whereas those with transposition are somewhere in between. And similarly, when we look at early childhood motor outcomes, again, compared to normal children, HLHS children have significantly impaired motor outcomes, and those with transposition are in between the two groups and closer to what would be expected for a normal child. Now, this divergence between these two groups, we've seen in neuroimaging studies as well. This is a study that we published a few years ago looking at pre- and post-operative brain MRIs in the neonatal period, comparing patients with transposition to those with hypoplastic left heart syndrome, and specifically looking at the rate of growth overall of the brain, as well as in regional areas of the brain, including the white matter. And what we can see here is that both globally and regionally, patients with transposition have a faster rate of growth in the brain compared to those with HLHS. And this difference, again, is intuitive, given the fact that in transposition, you end up with essentially normal cardiovascular physiology in the newborn period. But although they appear to have this leg up, at least in the newborn period, compared to other severe forms of congenital heart disease, we've learned that they are not spared when it comes to neurodevelopmental impairments later in life. And much of what we have learned regarding neurodevelopmental impairments in transposition is from the Boston Circulatory Arrest Study, which, among other things, has allowed a longitudinal assessment of a well-characterized group of patients with transposition of the great arteries that has undergone an arterial switch operation. And what this group has shown is that in both childhood and adolescence, although these children exhibit normal IQs, if you were to give them a standardized exam, many of them struggle in the academic realm. 1 in 5 exhibit behavioral problems, 1 in 3 require tutoring, 1 in 4 require remedial education, and 1 in 6 repeat a grade. There is high variability from patient to patient, but does suggest that there are significant impairments that these children have to face. The Boston Circulatory Arrest Study also evaluated psychosocial health, which is mental, emotional, and social well-being of the child. And at 8 years of age, psychosocial health is reported to be similar to normal children for those with transposition, but worse when comparing to children with other chronic illnesses such as asthma or juvenile arthritis. And then in adolescence, however, we start to see that psychosocial health is reported to be worse than normal peers. And the other, I think, important finding from the Boston Circulatory Arrest Study, due to the longitudinal nature of the study, is that they've reported that neurodevelopmental impairments at any time point is associated with worse psychosocial health and quality of life in adolescence. And this is really an important finding because we know that even in normal children, psychosocial health and health-related quality of life are extremely important and have an impact on mental health, on the ability to gain independence and to contribute to society down the line. So this sort of sets the scene for some of the issues that these patients face. And I'm going to spend the rest of the talk focusing on what we've learned from neuroimaging studies. And that's because at our center here, our research program has really been focused on neuroimaging, particularly in the neonatal period, including in patients with transposition of the great arteries. And this is early work from my mentor, Patrick McQuillan and Stephen Miller, where they enrolled newborns with congenital heart disease, including transposition of the great arteries, and performed pre and post-operative brain MRIs and followed them for neurodevelopmental outcomes. And what they found is that a third of these patients exhibit pre-operative brain injury, either in the form of white matter injury seen in panel A here, or small focal stroke as seen in panels B and C here. And a third of them go on to develop new brain injury post-operatively. I think it's important to mention that we typically call these clinically silent brain injuries because the baby doesn't really have overt clinical signs of having injury on the MRI and was only really diagnosed based on the imaging study. Since those early observations, there have been follow-up studies to identify risk factors for these forms of injury. The group at CHOP and others identified that the level of oxygenation and duration of hypoxia in the newborn period is highly associated with risk of white matter injury or periventricular leukomalacia. And as I mentioned, in our cohort, we have a fair number of patients, and more specifically on the preoperative MRI, that exhibit small focal stroke. And very early on, our group made an observation that there was an association between the need for a balloon atrial septostomy and developing these small focal strokes, which continues to be seen in the current era of our prospective cohort as well. And not surprisingly, this finding led to a great deal of, I think, controversy and angst, because as we all know, this is a procedure that is life-saving and required for many patients, but there was some discomfort that we could potentially be causing some harm. Now, a couple years ago, after accumulating more patients in our prospective cohort study, we were able to look at the relationship between these neonatal brain injuries and neurodevelopmental outcomes, including in patients with transposition. And what was reassuring to us was that small focal stroke, particularly in patients with transposition as seen by this blue line here, was not associated with worse cognitive or motor outcomes at 2.5 years of age. And this is the multivariable analysis that I'm presenting here. What was interesting is on the univariate analysis, actually, patients with stroke did better on motor and cognitive outcomes compared to patients with no injury. And we think that's because when you have a balloon atrial septostomy, although you might end up with a small focal stroke, the hemodynamic state of that neonate improves and likely prevents white matter injury, which we show to be more associated with worse neurodevelopmental outcome. So here we can see that subjects with moderate to severe white matter injury had significantly worse motor outcomes as compared to those with none or minimal white matter injury. So this was, I think, really important data and reassuring data to explain some of the earlier observations, at least in our cohort here. So when we switch gears to start talking about ways we can improve neurodevelopmental outcome, I sort of think of transposition in this very simplistic model where these, you start out with abnormal fetal physiology with decreased oxygen and nutrient delivery to the brain due to abnormal streaming patterns. There is variability in perinatal physiology depending on the degree and duration of hypoxia and the status of the atrial septum and whether or not there's pulmonary hypertension. And although these patients have an early arterial switch operation with restoration of normal physiology with technical outcomes that are quite good in the recent era, many of these patients go on to have some degree of neurodevelopmental impairments, as well as issues with psychosocial health and quality of life. And again, this is a very simplistic model. It does not take into account genetic and environmental factors or the small percentage of patients that need reoperations, but does suggest that maybe what's happening in utero and in early life has a lasting impact on neurodevelopmental outcome, and perhaps our interventions that we study may be focused in early life and even prenatally. So along those same lines, we did a study a few years ago where we looked at whether prenatal detection of transposition can improve neurodevelopmental outcome. And this was again pulling from that prospective cohort study where patients had both pre and post-operative brain MRIs. And what we found was that in fact, prenatally diagnosed subjects, as seen in panel B here, had less severe brain injury compared to postnatally diagnosed subjects. And more specifically, there was a higher percentage with moderate to severe white matter injury among the patients in the postnatally diagnosed group. And then similarly, when we looked at brain development, we looked at a measure called fractional anisotropy, which is essentially a measure that is supposed to increase with increasing maturity. And we found that prenatally diagnosed subjects had a faster rate of brain development in the perioperative period compared to those that were postnatally diagnosed. And this was on the heels of a study from Johanna Calderon, which looked at whether prenatal detection has a lasting effect on neurocognitive outcomes. And they did find that neurocognitive outcomes were significantly better after controlling for several confounders in patients that were prenatally diagnosed compared to those that were postnatally diagnosed. So this is really a tangible, simple intervention that could potentially have long-lasting positive effects on neurodevelopmental outcome, which is simply prenatally diagnosing these patients. And I think that's a little easier said than done because unfortunately, transposition of the great arteries is still not a lesion that we have perfected when it comes to prenatal detection. Here we can see the experience at a Canadian site in Edmonton, and then this is the experience in Boston, where over time we can certainly see an improvement in prenatal detection of transposition as there have been updates to the obstetrical screening guidelines, but we have certainly not achieved perfection, and we have not approached 100% in terms of prenatal detection. And this is an area that can certainly potentially improve long-term outcomes for these patients. And then the second area to discuss, which we heard a lot about on the last transposition webinar from Mike Seed, is the timing of operation. And his group published this recent paper in Circulation where they looked at brain size and neurodevelopmental outcome based on the timing of your operation. And this included patients with associated ventricular septal defects, but did show that brain size after the operation was smaller in those that underwent a later repair compared to those that underwent an earlier repair. And I think this figure is one of the most important figures from the paper, because it shows that the age at operation, something that's happening in the newborn period, is associated with an outcome that's measured 18 months later. And specifically that the later you have your operation in the newborn period, the worse your language outcome. So if you imagine normal here is around 100, a lot of these patients are sitting well below that range in terms of normal language outcomes. So to conclude, I think there's two major take-home points from this talk. The first is that I think on the surface, when a lot of us see these patients in clinic, they seem to be doing just fine. And certainly if you were to measure their IQ, they do well, similar to peers that don't have congenital heart disease. But if you take a deeper dive, they do struggle with academic achievement, with school performance. Many have behavioral problems and issues with psychosocial health. And so an important component of this is ongoing developmental screening for patients with transposition of the great arteries throughout the lifespan. Here you can see our neuropsychologist with one of our patients. And the purpose of this is to identify these issues early on so that we can intervene and optimize these outcomes for these patients. And the second take-home point is that as we start to focus our science on improving neurodevelopmental outcomes, intervening early on in life and even in the prenatal time period might be where we should focus our attention to improve these outcomes, including increasing prenatal detection of transposition of the great arteries, as well as optimal timing of the arterial switch operation. Thank you.
Thanks, Shab. That's terrific. I love hearing all that up-to-date information, and you're really pushing the field forward. I just have to fix one thing on my screen here. I certainly appreciate everyone for staying during this webinar. It has just been fascinating to get people from all around the world, not only in the audience, but on the panel. And I'm happy to introduce Dr. Victoria Stoll from the University of Birmingham in the United Kingdom. My power here, sorry. I came across her manuscript as I was scanning through the ACHD literature, and I think this is just a fascinating way of looking at the fact that we're looking at pregnancy outcomes after this operation would have been foreign to us 20 or 25 years ago. And I'm really looking forward to hearing her work. Her research interests are wide, and they include assessing all types of outcomes in the adult congenital heart disease population. So Dr. Stoll.
Great, thank you very much, and thank you for the invitation to speak. So I'm going to take you through some of our work that we've conducted in the UK. If I can get my slides to progress. There we go. So I have no conflicts of interest, and I'm funded by our National Institute of Health Research as a clinical lecturer. So I hope this will work. I'd be really interested to see how many of you would routinely recommend a cesarean section for a pregnant patient who's had previous transposition surgery and has a dilated but a stable aortic root dimension. So if you could just give me a poll, I'd be really interested to see what your kind of thought process is at this point. Does it just come? Oh, there we go. Okay, so kind of quite split, quite a mix. Okay, well, I'll present what we've found, and then I'll be interested to see what you think at the end. So, as you've just mentioned, you know, the thought of women having undergone this operation, getting to the point where they are now having children was unthinkable many years ago, but actually now we have an increase in population, and it's going to continue to increase, of women who are wanting to have children who have undergone the arterial switch operation. So we were very interested in looking at what the effects of pregnancy upon these women are, because of the physiological stress that pregnancy involves with the fluid, the volume loading, and the sustained cardiac output that's required for the whole of pregnancy, as well as the hemodynamic stresses on the aorta, which we know from other aortopathy conditions can be a complicating factor during pregnancy. So we run a very extensive pre-pregnancy counselling service with our patients in Birmingham, and like to talk to them about the risks of undertaking a pregnancy so that they can make an informed decision. And we very much felt that the literature that was out there for women following the arterial switch operation felt very different to our kind of contemporary practice that we had a feel of. So the main paper that was previously published was from 2010 by Tobler et al. And they had 9 women who had had 13 live pregnancies and 2 complications. One of this was non-sustained VT in a patient who had an impaired left ventricle, and the other one was a thrombosed mechanical valve. So that gave them a 15% rate of cardiac events. But 67% 6 of these women had actually undergone a second intervention after their arterial switch operation, and so really did feel like they represented a very early cohort of the arterial switch operation patients, and not so reflective of the patients that we are now seeing coming through. So we decided to assess our own practice. So we collected data on all of our female patients who are under our follow-up, and we identified those that had been pregnant or were pregnant from their records in our cardiology clinic, and we looked at their imaging of their ventricle and their aorta before, during and after pregnancy. And then we looked at whether there are any adverse maternal outcomes. In particular, we're interested in arrhythmias, heart failure, aortic dissections, and any acute coronary syndromes due to the coronary anatomy challenges that these patients often have. And then we also looked at how do their babies do, because, you know, obviously for a woman, that's pretty much what they are more interested in. If you give them the choice between, am I going to be okay or is my baby going to be okay, it's always the baby that they want to know about. So we wanted to know whether these pregnancies were ending successfully with a baby of a good weight at a decent gestation without long-term complications. Sorry. So what we looked at was very standard routine imaging that, you know, we're all undertaking in these patients. So we looked at their echo parameters for their left ventricular size and function, the dimensions of their aortic route at the sinuses of Valsalva, whether they had any aortic regurgitation in the grading of this, and whether there are any right-sided valve defects present. So we defined aortic root dilatation according to a diameter of greater than 95 percentile for their sex and age, and then we calculated their Z scores for the dilatation, and also graded any valvular lesions according to the standard American Society guidelines. So we identified that we had 55 women that we were following up at that time point who were older than 16, who'd undergone the arterial switch. The mean age of these women was still young, in their early 20s, and 15 women had been pregnant or were pregnant. We'd had 25 pregnancies, and by the time that we finished the study, 24 of those had been completed. The background to these women was that 10 of them had a diagnosis of transposition with intact septum, and 33 women had transposition with ventricular septal defects. And then 2 of our women had what we classed as complex transposition. So one of them had a coarctation of the aorta, and the other one had RVOT obstruction. So most of our patients had undergone the arterial switch during the neonatal period, but we had 5 patients who were in the early era for us of the arterial switch operations who underwent them at an older age. And 4 of those patients had undergone previous pulmonary artery banding. The 5th patient actually presented very late at 3 months old, and that's why their surgery was delayed. Our cohort, we found that 40% of our women had needed further intervention after their arterial switch, but before having their first pregnancy. So a bit less than that 67% that the Tolber paper had reported. And the most common reason for us was pulmonary artery stenosis, as we've heard from the previous speakers, being significant complication. So just looking at our demographics in a little bit more detail, I'll just draw your attention to the age at first delivery. So our women are having their babies relatively young for a Western population. And I don't know, we'll be interesting to look into that. Is it because they've been told that they can't have babies at any point? Or, sometimes if our women have very dilated aortic roots, and if there's regurgitations at some points, not so much with transposition, but some of our other patient populations, we do sort of say, well, maybe have your babies earlier rather than leave it until you're in your late 30s, 40s. So it would be interesting to see why that is quite so young. But equally, Birmingham is quite an urban population, and we do have quite a lot of young mothers. In terms of the number of pregnancies, so there were 7 women who were multiparous and 8 who it was their first baby. In terms of their cardiac lesions, so these were really very good arterial switches in that there was very little aortic regurgitation in these patients. Only 2 had moderate and 8 had no aortic regurgitation. 5 of the women had neo-aortic root dilatation. And as you can see, there was some degree of tricuspid regurgitation, but again, it was in the mild and trivial categories. So in terms of how did our women do during pregnancy, so there were no episodes of arrhythmia, heart failure, aortic dissection, or coronary events. 12 of our women, we had serial echo, including a scan after their most recent pregnancy. And only 1 of our women had any progression in the degree of aortic regurgitation. And that was from none to mild. And that was over a period of 12 years between her first and third pregnancies. So, as we've heard, this aortic root dilatation is actually a dynamic feature. And would this have happened anyway without her having pregnancies? One obviously can't be sure. The reassuring thing was that in our 5 women who had the dilated neo-aortic roots, we didn't see any further dilatation of that caused by the hemodynamic consequences of pregnancy. So just looking at the aortic root dimensions in more detail, so our mean aortic root dimensions were 33 millimeters, and in those with the dilatation it was 38 millimeters, and you can see that post-pregnancy this didn't alter, they weren't any bigger, which is very reassuring. So in terms of other outcomes, all of our women had normal systolic function prior to their first pregnancy. 2 of the women had dilated LV dimensions, but this didn't deteriorate after pregnancy. We had 1 of our ladies who had a decline in her LV function, which was 8 months after her second pregnancy. But this was a lady who had very complex surgical history in the past, including a resection of a pulmonary artery aneurysm, a pulmonary valve replacement with RVOT patch enlargement, and a right coronary artery bypass graft. So she was certainly a sort of outlier in terms of the severity in our cohort. So it wasn't that surprising that her LV had declined. What we found quite interesting was the fact that in her 3rd trimester echo, her LV function actually still looked normal. It was just post-delivery that it seemed to have become impaired. In terms of the mode of delivery, so 19 deliveries we were able to find out how the women had their babies, and for 42% of these women they had a normal vaginal delivery. 21% of the women had an instrumental delivery, and 37%, 7 women had a cesarean section. And 2 of those cesareans were, or 2 of the deliveries were preterm. One of them was for spontaneous labor at 35 weeks and required the cesarean for a breech presentation. The other 2 cesareans that were emergencies were for a delay in the second stage of labor, and 5 of the C-sections were elective. 2 were for fetal indications of a breech position, and 2 of them were in the same patient who we advised to undertake a cesarean because of her dilated aortic root dimensions. And then the further cesarean was for maternal choice. In terms of the babies, they had a normal gestation in most of the pregnancies, apart from those 2 that were delivered preterm. And that was at 38.5 weeks was the mean. And they had a good birth weight, and none of the babies had any cardiac disease or any neonatal deaths. We don't have longer term follow-up yet. Sorry, my pointer's doing something funny. So in conclusion, this is the largest to date study of pregnancy outcomes following the arterial switch operation. We found that our women tolerated pregnancy well with no adverse maternal cardiac events. We were very reassured to see that there was no deterioration in the aortic root dilatation following pregnancy, and that the patients who did have changes in function were those that one would anticipate with that very complex surgical history in the lady who had the decline in LV function, and the progressive change from none to mild aortic regurgitation, but over a 12-year period following the 3 pregnancies. And we were really quite pleased that actually only 2 of our modes of delivery were dictated by the mother's cardiac considerations rather than the pregnancy itself or the mother's choice. We think that's something that we should be looking to hopefully achieve in the future with these women, that they should have the same choices as other women who have become pregnant and need to deliver their babies. So I would like to just re-ask the poll whether you would still routinely recommend a C-section for a pregnant patient with a previous transposition but a dilated but stable aortic root. I'd be interested to see if any of you have changed your opinion. Okay, so great, I've convinced you. So I think that's very much what we would feel our data support, that, you know, actually the aortic root doesn't suffer during pregnancy. We would still recommend keeping an eye on it to make sure, because these are a small number of women that we have undertaken the study in. But I think when you're pre-pregnancy counselling these women, you can actually reassure them that they don't have the same features of problems with their aorta as women with underlying aortopathies like Marfan's or Loeys-Dietz, and actually we can be a bit more relaxed about these patients. So thank you very much for your attention. And again, thank you for being invited to speak. I'm very honoured. And if anyone has any questions or comments, I think that the paper this is based on is one of the ones that will be distributed. But if anyone wants to email me, then feel free. Thank you very much.
Thanks so much, Victoria. That's just a fascinating series. And, you know, first of all, we know transposition is a boy disease. So the fact that we have that many women in decades of follow-up is just fantastic. We only had one surgeon on the panel, Dr. Vida, as well as Dr. Agati, but, you know, being able to talk about these results is such a tribute to what the surgeons, as well as anesthesia and intensive care nursing, has done over the last 3 decades to get to the point that we can be talking about these types of issues. So I want to thank all of the panelists that have come from all over the world. I hope we have still a number of people, probably close to 500 counting our YouTube. And if people can stay past noon in the East Coast, 9 where Shab is, I don't know what time it is in India, but if people want to stay a little bit longer for questions, I'm going to turn this back over to Grace. And thanks to the panelists again.
Thank you very much. It was really an amazing webinar. We are very happy to have all of you, and we already are having great feedback. We have some cool questions, but maybe we could have some live discussion. I think maybe it's going to be interesting. So any of you who are still able to stay and you want to make one question live, you can use the raise your hands on the chat, and then we can allow you to talk if you have any question for the pool.
I just wanted to mention one other thing, because Shab showed some of the papers from the Boston Circulatory Arrest Study. The follow-up cohort is now 30 years old, and we are in the process of doing their full quality of life testing. And now that I've heard Dr. Stoll, I'll need to be sure that we're adding questions about how they've been advised, for the women, how they've been advised, and for both genders, what's happened with their children. It was really wonderful to put that in there, and it'll be nice to see the follow-up in the cohort. And there's questions coming in, Grace, okay?
Okay, so let's see.
Victoria, can you please stop your share? Yeah, thank you.
Sorry, if any of you who have raised your hands want to talk, you can unmute yourself. And
Buenos días.
This is from Mars.
okay, do you have one question?
We exaggerate.
Okay, so there's a lot of questions that we are not able to answer on the Q&A. I'm going to ask some of them for you. So this is an interesting question about the risk of coronary artery disease with patients with ASO. So do you think that we should place these patients on any medication, aspirin, statin, as a secondary prevention? What do you think about it? Question for all the panel. So any of you?
I'll take a shot at it. I don't think there's enough information to know that we can put these patients on statins at the present time, because we don't know the mechanism of why they're having these abnormalities. You know, the intimal proliferation is certainly something of concern, and we see it happening relatively young in this population. And, you know, I think following over time, you know, there may be an opportunity to do a study to see if it makes a difference or not. It would be hard to know exactly how to measure problems because the rate of them having coronary artery, you know, sort of myocardial ischemia is pretty low. So I'm not sure that it would make all that difference. That being said, statins are pretty low risk in the population. And so it's one of those things that it might not hurt, but I don't know. I don't think we know that it would make a difference. I don't know what other people think.
Meryl, what do you think about aspirin, especially for the younger baby postoperatively? Because I think there's a lot of variability in practice on aspirin use as well.
Yeah, I think it's very similar that we don't know if it makes a difference or not. And I think people tend to use it because it makes them feel better, honestly. And I don't know that, you know, putting somebody on a baby aspirin makes any difference. I know that I have done it in the past in patients who have had coronary revision. So I'm in that group that it makes me feel better, but I don't think that we have any data that tells us that it makes a difference.
Another question that is interesting maybe for us to answer live is about the association of autism and AS and TGA.
I can answer that. I think we don't know exactly. In our anecdotal experience here, we do see a fair number of patients with autism-like behavior that are status post-arterial switch operation. That's definitely an answer. A question we're hoping to answer through CNOC, the Cardiac Neurodevelopmental Outcomes Collaborative, when we have opportunity to do sort of a multi-center approach to diagnosing these behavioral problems. But based on our experience and others, we do strongly recommend that these children are screened for autism along with their developmental screening throughout, you know, early childhood.
Okay, very good. Any other question or comment from the panel? If you want to wrap up, guys.
Thank you.
Sasha.
Thank you.
Sasha, do you want to say something? Unmute.
This is too much women there, so they unmute me. Yes. No. Thanks a lot. Thanks a lot.
Not too much, just enough.
But the right one.
Guys, thank you very much. It was a really an amazing webinar. Thanks for all of you that stayed with us until now. And if you're able to watch any part of this, thank you. All of this is going to be on YouTube. You're able to watch again, to share with your colleagues. And we are always open for questions. If you have questions for any of the panelists, of the speakers, anyone, you can send to us when we are going to forward to them. We are here to make things better for our patients. That's the goal of Congenital Heart Academy. Follow us on social media, and thank you. See you on ECMO next Thursday. Bye-bye.
Thank you.
Only one thing, mass regards to one lady from Hawaii. She told me that it's 6 a.m. She was already on the web, and she thanks all of you, is Irina. So see you soon, see you tomorrow. Grazie.
Bye-bye.
Bye-bye.